Good morning. Good morning to everyone, and welcome to Turin, to the ONCA Conference 2024. I am Antonella Leso. I am the president of SIMPE, the Italian Pen Society. And here with me, there is Professor Ole Ljungqvist, the director of European Nutrition for Health Alliance. We will co-chair all the sessions of this day together. It's a real pleasure, and we are really honored for the opportunity to have in Turin and in Italy the ONCA conference here with us today and online. There are delegations of 20 countries and a lot of people connected with us to this policy summit that will be plenty of scientific activities and leisure activities and other things and some surprises. I'd like to thank first of all, the ONCA staff. They have done really great work from months to organize everything. Would like to thank as well Andrea Pezzana, which is the coordinator of the Clinical Nutrition Network of our region, and he is a co-organizer together with me. Thank you, Andrea. Now, without further ado, I'd like to say a few words about the short story of Italy in ONCA. We joined 3 years ago only in ONCA, and the first commitment of the SIMPE board was to create a dashboard that you all know very well. This dashboard is comprehensive of every detail about malnutrition and nutritional care in our country. It is comprehensive of all the aspects, from prevalence of malnutrition to reimbursement, education, policies, and so on. This has constituted a structure and a context for our further engagement in ONCA. And subsequently, there has been a crescendo of activities, culminating in the Malnutrition Awareness Week that we are going on until 2 years, 3 years. And we, every year, have been able to do better, both in terms of awareness and involving people in it. Our strength is our team, as you can see, and this is the first time we are really proud about it. It's the first time that we get together scientific societies from in the left side of the screen, Patients Association on the right side of the screen, and medical nutrition industry and health economics as well. So I hope as well we will do our best with this global initiative. We hope to have the help of the Ministry of Health and health managers overall, let's say, and we have then someone real testimonial for it. Now we will share a 1-minute video that we prepared for the Malnutrition Awareness Week last year. If you can please go with just a minute of it. well. This is the subject, this is the theme, so thank you for watching. And let me now introduce on the stage the authorities of Piedmont region to bring a message of welcome. So I'm inviting Dr. Franco Ripa, which is the General Director of the Regional Health Department. Please, the stage is yours.
Allora io parlo in italiano,
okay,
anche perché siamo più diretti. Volevo innanzitutto dare il benvenuto a tutti voi che siete qui in presenza e anche chi è collegato in online. Questo è uno sicuramente degli eventi più importanti che si svolgono nell'anno in Regione Piemonte, e quindi per tutti noi sicuramente è un momento di grande livello. È chiaro che il problema che stiamo affrontando è un problema importante anche dal punto di vista epidemiologico, anche perché gli impatti che poi abbiamo sia sulla salute, ma anche poi su tutto quello che si porta dietro l'aspetto legato alle patologie, che vanno anche a creare dei momenti di inevitabile approccio intersettoriale. Vedo Jacopo Rosatelli che rappresenta appunto il comune, e quindi è sicuramente un tema importante sia per quanto riguarda la programmazione sanitaria. E Regione Piemonte tra l'altro ha una rete molto evoluta con dei grossi livelli di connettività sia con il Ministero ma anche con gli utenti con cui lavoriamo su delle progettazioni assolutamente comuni, e credo che quindi dovremo poi dare seguito alla giornata di oggi in un briefing in assessorato per continuare con quello che oggi viene detto, per cui ringrazio in particolare Antonella Lezzo e Andrea Pezzana, che sono, diciamo, i fulcri della nostra rete con cui stiamo fondamentalmente già lavorando bene, ma su cui andremo a fare sicuramente delle progettualità future. Grazie ancora.
Thank you very much. I'm trying to recap in English for you all. I'm happy and honored, he said, to be here and welcome all the participants from everywhere in this hall and online. It is a really important, ONCA is a really important initiative. Nutritional care is a problem to be seriously faced, and we care very much about it. We must do it in a multi-sectorial way. Piedmont region has strongly wanted and supported clinical nutrition network. This is a solid reality in our region, and we are very interested to go on and do better. So we want to have a brief after the conference on the contents of this conference, and let us know and be updated with anything will happen here today. Thank you very much.
C'è Rosatelli, c'è qui.
Ah, ok, perfetto. Sì.
È arrivato.
Okay, so here with us is Dr. Jacopo Rosatelli, which is a counselor for welfare, rights and equal opportunities of the city of Turin. Thank you very much for being here.
Thank you. Thank you very much, dear guests, dear Mr. Ripa. On behalf of Mayor Stefano Lorusso and the city administration, I'm honored to welcome you to Torino for the International Optimal Nutritional Care for All conference, which our city is pleased to host, and especially here in this beautiful Teatro Regio. According to the definition of the World Health Organization, health should be conceived as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. In the spirit of the Italian Constitution, health is a fundamental right of the individual and an interest of the community. In short, there is no health without social justice, and a healthy society is a society where each person's right to health is guaranteed. This is especially evident in policies addressing food inequalities. Torino is continuously fostering many practices, projects and policies to make the food system more sustainable and fair. considering the different dimensions of food: environment, culture, economy, health, social justice. The importance of food issues has been evidenced in 2017, when the right to food became part of the statute of our city. Quote, "The city promotes the implementation of the right to adequate food, understood as the right to have permanent and free access to quality, sufficient, nutritious, healthy, culturally and religiously acceptable food, which guarantees the mental and physical satisfaction, individual and collective, necessary to lead a worthy life." In this brief address, I would like to underline two issues that are very important to me and to the city administration. Firstly, nutritional care is a fundamental part of health promotion and education. The city of Torino has recently signed a memorandum of understanding on health promotion and prevention policies with the Azienda Sanitaria Locale Città di Torino, the local branch of the regional health system. This memorandum includes a program aimed at promoting a culture of nutrition for all levels of the supply chain, from producer to consumer, healthy and sustainable, fair and available to all, and supported by alliances and synergies between various stakeholders. Secondly, nutritional care is strictly linked to equitable access to food, which must be considered a fundamental human right. For this reason, during the COVID-19 healthy emergency, the city of Torino created Torino Solidale, a network of charities which organized distribution, first weekly, then monthly, of basic necessity goods to families reported by the municipality. Since then, Torino Solidale has evolved, becoming a stable network of hubs promoting food solidarity and community empowerment. So, I wish you good work for your Congress, and I hope that your stay in Torino will be pleasant with this sun, hopefully. Thank you very much for your attention. A good work.
Thank you very much, really, for being here and for these words that we appreciate so much. Thank you. Now the stage goes to Professor Ljungqvist to have some words of welcome for all of us.
Thank you. Well, for me, it's always a pleasure to come back to Italy, and especially when it comes to food, I'm very happy to be in this country. I think we all are. Actually, this is the 10th time that it's 10 years ago since we started the Onca campaign. So you can see it's still very viable, and it's great to see so many of you here, old friends, and also many new faces, which is also very good for the promotion of what we're doing. So we're here to translate nutritional care science into policies, and that's really what we have been trying to do with the Onca campaign for a long time. And I think that the campaign is really thriving. We have our 21st country. Norway is now on the way in. We have 15 plus malnutrition awareness weeks, and Espen is actually doing this worldwide also. And we have new delegates coming in to join us as we move along. We produced the manifesto, which is a new mandate of the EU, and we're working with politicians and institutions to drive these things forward. And in all of this, we really want to keep the patient collaboration at the core of what we're doing. And we had this morning, again, the patients had a session to really move things for us. And we'll be, of course, hearing more from them during our sessions here today and tomorrow. We're accelerating implementation, and I'd like to point out that there is a EU4Health National Implementation Fund, which is there to be, you can apply for support to implement new practices and benefits in healthcare. So that's something to keep an eye on, and we're looking to move this forward with the Czech group. that have with a memorandum with the Minister of Health by the EU presidency. And it's also about controlling what we're doing, because we tend to believe that we know what's going on in our complex world of healthcare. And I'd like to just spend a couple of minutes on a project that I've been running aside of this, which is called Enhanced Recovery After Surgery. And this is all about getting patients to recover, and it really has a lot to do with managing nutrition and stress during the phase of surgery. And what we've learned is that we have to realize that the care pathways are complex. And this is true also for many of the problems that we're facing in patients with poor nutritional status. Oncological patients, diabetes patients, patients with lung disease or other chronic diseases. There are many care elements apart from nutrition that we need to manage in order to make nutrition work in the first place. And there are many, many caregivers involved in the patient's journeys that they're making. And we tend to work in silos in healthcare because we simply don't have time to know what's going on in the other parts that the patient is going through. And we have poor control over the entire pathway. And this is something that we try to grip in the Enhanced Recovery After Surgery protocols that we're doing. And in surgery, and many surgeons around the world seem to think that we have a basic standard of care. And if we had the perfect standard of care, I'm just going to show you what that would look like. It would actually be the outer ring of each one of those circles. And down here, you can see all the different treatment elements of an enhanced recovery after surgery pathway. And there are 4 different hospitals that I have trained myself, where we have 50 patients, consecutive patients before training. So we looked at what is actually going on in these hospitals. And you would assume that many hospitals would be much wider. They would be at the blue level. But in fact, you're seeing 4 very different pictures, right? And even some of the things that you would be absolutely certain would be present for all patients every time, such as antibiotics for colorectal surgery, which is what this is all about. I've highlighted that in red. And you can see that, yes, it is happening, but not all the time. And you can see there are a lot of different things that are not happening. And people have no idea, because we don't measure this. We measure sometimes outcomes, but we don't measure the processes that lead us to those outcomes. That's been the trick of enhanced recovery, is to help people see what's going on in their specific unit so that they can move into a better compliance with all these care elements, that all of them make a difference for the outcomes. And what has that done for surgery? Well, if you look at the graph there, the more of the elements that these hospitals are able to follow, the better the outcomes are going to be. And that's really no surprise if you think of it, because if you do more things right, of course the patients are going to feel better. It's about knowing that it's actually happening. This has been shown to reduce complications and length of stay substantially. And of course, that brings a lot of savings to the people who are running healthcare for us, and eventually all of us, because somewhere down the line, we're all paying for it. And the way that we've been addressing this is by using the evidence guidelines. We have a lot of guidelines for other treatments as well, so we could actually use this. And when we have structured implementation, where we identify the pathway of the patient and who is involved, we audit all of them, all the time, for every patient. And we feed back to the team that is actually treating on the floor, because that's where it's happening. And these are the people that govern the care that is actually eventually being given. So this is what has made the success. And we built an international network. We have it already here. And we're doing research with the data that we're assembling, because we're doing it the same way. So this has really improved outcomes, and it's interesting to see that in this region of Italy, there's been a movement for this, and I know it's been very successful as well. So this is I'm preaching for the converted here, but I think it's something that we can bring home and think about. And of course, most importantly, it's good for the patients. So I think that we can use these principles in other parts of medicine as well. We can use the evidence guidelines and we could build the pathways and build teams around each one of those pathways, the way they look in different hospitals. But we need to audit and feedback to the people because they go to work to try to help. It's just that they don't know how well they're doing it, again, because we don't measure it. So I thought this could be a little bit of an introduction to the next session, actually. With that, I think we'll move on to and just say welcome to everybody. And as part of the organization here, I really need to point out there are a few people that have done a tremendous job to make this happen. Jost, of course, who is the leader of the pack here, but we have also Konstantina, Mariana, Moira, and Francesca, and I think we should give them a big hand. And of course, this would not be possible to do without the support of all these fine organizations, but also the industry that is helping support this. So we thank you for your contribution and support for the ONCA. Okay, now we're moving into the first session, nutritional care. How do we get from awareness to control? And we have 4 speakers for this with different backgrounds. 2 of them are going to be with us online. So we'll have them all join us. But the first one to speak is a very dear person, Andrea Pezzana. He is one of the co-organizers here. And he is actually running the nutritional network here in this region of Italy. And it's a pleasure to introduce you. And you are going to tell us about how you set the scene implementing nutritional care for optimal health. So the floor is yours. Welcome.
Thank you. Thank you so much. Hi, good morning. Thank you all for being here. Thanks to moderators for this very, very kind introduction. This is really the opening, setting the scene. We are in a theater, so setting the scene is quite important. And implementing nutrition care for optimal health, we will talk about what can be considered as health nowadays. We will consider the keywords of care and optimal, but I have to start apologizing because probably I will a bit widening the perspective. We will not just talk about clinical aspects. Of course, malnutrition remains the focus. But let's try to open a bit towards a wider perspective and try what we can do about that altogether. These are the main points of the agenda. I'm kindly asking the moderators, when I have 2 or 3 minutes left, can we just give me a sign? Thanks. So we'll start trying to understand the complexity of malnutrition. You know, the problem of facing with complexity is try to make it simple, but without losing the interesting part of being complex, without losing the real trick of being complex. We can start with 2 pictures. They were made by the joint committee of the UN, the FAO, and the WHO when it was launched, the United Nations Decade of Action on Nutrition, 2016 to 25. Due to pandemic period, it will last until 2030, so there is still a lot of work to do. Nutrition at a glance is understanding that good nutrition, of course, what we see into our hospital wards at home with our patients is the final result of something that started really very far away. So it starts from environment, it starts from lifestyles, from how is and where is food produced. Why does it matter under the clinical point of view? Because we have seen and we will see the impact on costs, on quality of life, both of patients and families. The complexity of these problems makes it absolutely untreatable from single professionals, and we have to cope with it together in large groups. The help is that facing the global nutrition challenge can be really treated, must be considered starting from different point of view, and the 6 action areas that are mentioned in the document of the UN Decade of Action on Nutrition is really helping us. Well, the situation is quite well known. Malnutrition is a condition. We've heard it very well in this very interesting session together with the Association of Patients this morning just upstairs. The consequences are really a lot: quality of life, clinical aspects, costs. But let's just start on the number of the problem. It affects, this is a 2021 document, but we know it was underestimated and the problem is increasing. We have really millions and millions of people in Europe that are suffering from that are receiving very often not adequate cures and cares, that very often are not recognized, undertreated. And the final problem is mainly, of course, for the patients and for the health professionals, but for the whole system that is getting more and more in trouble for that. We should know better the 6 pillars for nutrition action, because, of course, that's policy, that's not practical care, that's not practical guidelines. But in those 6 pillars, we can find something that could be really helpful in allowing a better resolution for, you see, what is now called the triple burden of global malnutrition. That's the coexistence of undernutrition, overweight, and obesity. And what is getting more and more important, even after the COVID lesson, is the hidden hunger or the micronutrient deficiencies. It is not visible, I would say, from outside, but the impact and the consequences on everything connected with prevention and treatment of chronic disease is definitely very strong. If we have to implement nutrition care for optimal health, we probably have to rethink the concept of health. We've heard it very well from the words of the representative of the local government. It's not, of course, the absence of illnesses, but One Health that has been now very well described by the One Health high-level expert panel that works in WHO together with many other organizations, is something that is due to the combination and the interaction between experts of many different fields. So the focus remains malnutrition and fighting malnutrition. But we have, as I said, to use a wider perspective to try to understand how environment, human, and animal are involved in that, to how the solution cannot be only the health minister, the health professional solutions, but must start from something that is related to society, to inclusivity, to equity, to the whole food chain, from production to transformation, from the role of the small-scale food producers. Everything must be known and probably renegotiated in the direction of a One Health promotion if we really want to win the war, the fight against malnutrition in all its form. We have a few helps towards that direction. The Global Nutrition Report, for example, is focusing on how health system, food system, and social protection system, as I mentioned before, must try working together. But also we have to understand if the scene is changing. Of course, there are some signs of change. We have some good trends, but there is still a lot of work to do. I very often start with a very, very old 1974 paper by Charles Butterworth that defined malnutrition as the skeleton in the hospital closet. It is probably yet in some settings, but there is still a lot of work to do. So the awareness of the role of nutrition started in 1974. If we read that paper now, well, it sounds quite modern, and that's not a good news. We had a lot of hopes when the Council of Europe, with the RESAP, gave very strong information and rules to the state members in order to implement activity against malnutrition in all its forms. Something has been done, but just a few years later, another paper was published asking if the skeleton was still in the hospital closet. He analyzed very interestingly the scientific literature on that topic. The number of published papers of clinical studies was definitely increasing. More awareness, but still a lot of work to do. And the first steps and the next steps of ONCA are really working into that direction. But probably we have to look for new, I would say, unusual and probably unexpected alliances. Because when we talk about malnutrition, we have to connect it directly with very strong social concerns, with the problems of hunger, with the problem of social inequalities, with the problem of differences, clear differences described according to the level of education, to the economic level of families. So we have to try to understand that there are different levels of frailty that we must know and that we have to work on. Another very interesting part is linking the problem of malnutrition to the biggest environmental concerns we are living. There is a very strong level of evidence, and I will show you some papers later that are helping us in understanding that just talking about malnutrition remaining strictly at a clinical level doesn't help us in understanding probably what is the only possible winning approach, that is the holistic one. Just for an example, we had an educational program for the Italian health professional together with the Ministry of Health. It was a great pleasure. When we prepared it, we thought of 20,000 health professionals following this program. We had to continuously update it because before the end of the project, more than 55,000 health professionals joined this educational program in order to understand the complexity of malnutrition, probably showing us how the academic programs are still quite old in order to give updated and absolutely useful information about malnutrition in all its forms. So probably the right scenario is starting from the, I would say, the scientific knowledge of the problem, but linking somehow the personal, local, and global perspective. The right scenario should be probably nowadays for every complex problem, starting from the person, understanding that we are sharing, we are a sort of, I would say, destiny community. We are sharing an environment. In that environment, we are part of a global part of the environment, humanity as a whole, and the planet with its resources. And probably also, when we talk about malnutrition, we must maintain a strong interest and I would say an eye on our patient, but try to understand what is before and what is after too. Who is helping us in understanding something more is, for example, the very nice work on that topic of the Stockholm Resilience Center. It's a pleasure talking about Stockholm here at your presence. The SDGs, the Sustainable Development Goals, has been developed by the Stockholm Resilience Center experience, somehow linked at different level, like a wedding cake, with the complexity of the food system, with the complexity of the food security and insecurity, with the cultural aspect of nutritional diversity, and this is the point of view we have to adopt. There is a strong debate. Do we have to focus more on tradition or on innovation? Which is the role, for example, of the local knowledge, traditional knowledge about food? There is a big role because it was really, even if not published, what we learned about food and safety and security of food is the final result of a very long clinical trial that started about 2 million years ago. Today's innovation is tomorrow's tradition, so there is a continuity, but it's also something that inspired somehow, I would say, the vision and the philosophy of the catering, the lunches and dinners during this event of ONCA in Turin. We have to find an interesting, I would say, wise and curious balance between innovation and tradition. It could be not only a key of lecture for the knowledge of our everyday food, but it plays a big role when we talk about prevention and also treatment of malnutrition. And I'm showing you, for example, one paper that we did as La Città di Torino together with Ministry of Health and the CCM, Regione Umbria, where in fact we have to learn a lot from tradition about food and malnutrition, but we have to, I would say, update it to make it more actual, starting from the new and scientific traditional evidence. Why that? Because probably the same worst food production that are creating and worsening malnutrition at all its level worldwide are the same production that are creating very big problems for the planet. So we must try a way to connect those aspects and try to, as the challenge is so difficult, is so complex, to create alliances, maintaining, of course, everybody its own specialty, its own competencies, but work really all together. Just a few words on what I called the Piedmont way. The Piedmont way, well, the Piedmont way starts from being in Italy, of course, because we have to recognize the great work that is done daily by our Ministry of Health. There are just some examples that I'm showing you here. For example, the first biggest national conference of nutrition that really treated every aspect from primary prevention to treatment of acute patients, from moving to home cares to everything is connected with food safety, food security, and malnutrition. But they also helped us, for example, with guidelines about the food in hospital, in school, in nursing homes. And the big, again, something that doesn't seem directly related to malnutrition, but it is, and very strongly, the very interesting and updated guidelines for the reduction of food waste. That is another absolutely not sufficiently used tool for fighting malnutrition. So now this is our region. Our region is divided by the health governments in 5 areas that we call homogeneous area. Homogeneous is interesting because the idea is try to give every patient, no matter where it lives, the same standard, the same quality, the same level of health services. We have 14 clinical nutrition adult units and 2 pediatric units, quite well distributed in the territory. Just a few numbers to understand what are we talking about. The number of the day of treatment, the average day of treatment of the last 2 years for home enteral, home parenteral nutrition in cancer patients, home parenteral nutrition for intestinal failure, the number of patients that we are treating every year with oral nutrition support for dysphagia and malnutrition, the number of consultations that we do into our hospitals, and the number of outpatients visits. They are definitely increasing because we still had, for the first of the 2 years that we analyzed, some of the ending effects of the pandemic period, so the number is definitely increasing. But just to show you which is the role for a network on that topic. We must thank, I'm always saying that, I have to say it here too, we must thank Professor Franco Balzola. He was our professor that really started the activity of nutrition and clinical nutrition in this region. He found, I have to say, very clever and interesting politicians who helped him in creating and improving the program of home artificial nutrition and creating the units, the clinical nutrition units, because in our model, this really makes the difference. Every health professional must know quite a lot of things about nutrition, but if we have into the main general hospital a unit that is completely dedicated from prevention to intensive care units in nutrition, that can really make the difference. Our region is working a lot in the area of food and nutrition and malnutrition in many other aspects. I'm just showing you a couple of projects. This is supported by the main 4 academic groups Università di Torino, Politecnico di Torino, Università Piemonte Orientale, and the University of Gastronomic Sciences. We have a very strong Turin food policy with an atlas, with an agenda that is working, is updated every 6 months, and really, this is a book that you can download freely from the Franco Angeli Editore website. And another big experience that is inspiring our region is the presence of slow food. Turin is every 2 years the city of Terra Madre, where small-scale food producers, local traditions, very strong and interesting alliances with health professionals, with experts in environment, in circular economy, etc., have a dialogue in order to try to understand how can the food be one of the solutions for the complexity we are living in. So this was the agenda. What can we say at the end? Malnutrition is really a cloud of words where every professional can find something to do for, but also every citizen, because we said we have a global, we have a local, but we also have a personal level that can start from example, starting thinking how are we trying to reach at least a few of those 17 goals. So a lot of work to do, a lot of unexpected new alliance to work on, and if many hands make light work, we could probably think as the best way to treat malnutrition like the last way of mixing together different ingredients. Until we find in the recipes and we recognize the single ingredients, of course, the final gastronomic effect can be very interesting. But if we really want to reach something that is more just than the sum of the single one, we have to work in a transdisciplinary way and find at the end a sort of competence that is not the sum of the singles one, but really makes the difference. And with that, thank you all and welcome in Turin.
Thank you. Thank you very much for that setting the scene in a very, very nice way. We will have a debate or discussion at the end of all the 4 talks. And now we're going to see if technology is with us, because now I hope that we will be able to catch Laura Del Campo online, and so that we can get... Oh, you're there? Oh, perfect. Wonderful. Welcome. Welcome. Let me introduce you.
Thank you.
Laura Del Campo, she is representing, and now I'm going to try my Italian, Federazione Italiana delle Associazioni di Volontario in Oncologia. Not too bad, huh?
Not at all.
But seriously, this is a very important patient organization working with the oncological patients. And I know you've been very successful in driving nutritional aspects as well. And we're going to hear you talk about empowering health through nutritional care. And we'll have the patient-centric journey to progress. So the screen is yours. Welcome.
Thank you really very much. It's an honor for me to be here with you, even if I'm online, but really I'm in reality with you. I am the director of FAVO, which, as you said perfectly, is the Italian Federation of Cancer Patient Organizations. Which is, of course, dealing very much with all aspects that regard the quality of life. This is our main issue. And of course, nutrition could not be considered in our mission and in our aims. I'm going now to share my screen. Let's see again if, okay, here it is, if technology works. Let's see, here it is. Can you see it? Yes, I see my screen in the theater. Okay, so just a few words about our federation. Our federation is a big network constituted by more than the 300 associations dealing with all types of cancer, providing all kinds of services to cancer patients and their families. We are, of course, very much organized also in local territories, in regional territories, and we also work very much with working groups representing specific needs of cancer patients. And in this regard, we have a very important working group about nutrition made from all the cancer patient organizations that are very much interested to advocate in this very important issue. So the challenges that we face every day are, of course, several. So from information to disparities, from rare cancers, neglected tumors, life after cancer, quality of life, and rehabilitation. Rehabilitation for us is very important to be considered as the oncological rehabilitation as a system of rehabilitation issues that go from physical to nutritional to sexual to cognitive and social rehabilitation. Only if we ensure this kind of rehabilitation, we can try to provide the better quality of life. In Italy, we have almost 4 million of Italians living after a cancer diagnosis. Of course, while we have very good news about it, like it happens all over the world, more than 30% of cancer patients really are healed, survive, and they have the same life expectancy as whoever never had a cancer diagnosis. So this is the great news. But on the contrary, more than 20% does not overcome cancer due to severe consequences of malnutrition. This is, of course, something that we cannot absolutely permit. And the thing that I always really want to underline every time that we talk about nutrition is that it happens too often that also patient advocates who know very well how important is nutrition during the cancer pathway, they even die for malnutrition. So this is the thing that, of course, is something that really worries us so much, because it could happen that maybe the cancer patient just doesn't know about the importance. And it happens, unfortunately, that that the health operators don't help him or her in this important sustain of nutrition. But people that really know perfectly how much important the nutrition is in the cancer pathway, this is something that, of course, worries out us even more. So, okay, of course, what can we do as a federation? Of course, as always in our style, we always create important alliances with scientific societies, with institutions which are focused on specific themes like the one I'm presenting, for creating the chart of the rights of cancer patients, for having an appropriate and fast nutritional support. This is a chart that we have done in 2016 together with SINPE, and with IOM, the Italian Association of Medical Oncology. And why we did it? Because we saw that cancer patients didn't know how important was nutrition. So we started already in 2016 to inform cancer patients and tell them how important it is to ask, even if the oncologist or the health operators don't tell him or her about the importance of nutrition, patients should be engaged and empowered for asking to have an appropriate nutritional support. Of course, as always, FAVO does, we always try to, before understanding how to work, we always organize important surveys within our national territory. And this was the first one that we presented, that we have organized in 2017, in which we have collected more than 1,000 questionnaires from cancer patients. Even, of course, if we could have considered a fewer number, because some questionnaires were not completed. But for example, we asked to the patients, since you have been diagnosed with cancer disease, have you been strictly following any diet? If yes, which one? Okay, this was yes. If you see here, it's a 24%, no, 75%. Since you have been diagnosed with cancer, have you been strictly following any diet? Which one? So they have answered, someone have been following a personalized diet, but that has been defined by a private dietitian or whatever, or nutritionist. Or just a few of them have a personalized diet that have been given from the center, the oncological center in which they are followed. Some just decided to follow a vegetarian diet, some others a vegan diet, but just like this, just because they heard that it could help. And then again, by whom have you been helped for being supported in nutrition? And so if you see 35% of cancer patients were recommended to follow a good nutrition by the oncologist, and then the other numbers that follow, the other percentage alone, so absolutely autonomously, and then with a private medical nutritionist, or by web, by television, and by advertising. So, of course, we have started to empower cancer patients not only for considering the importance of nutrition during, the therapies and whatever, but also in follow-up. So we have produced, again, together with all the cancer scientific societies, which of course are very much involved in nutrition, we have started distributing booklets for making also people that have finished their treatments to consider always the importance of being very careful about nutritional aspects. And all this work has been done in strict collaboration with the Italian Association of Cancer Patients, which is IMAC. IMAC is one of the founders of our federation, and it is an organization which is very much focused on providing personalized information to cancer patients and their families, all about all the aspects that regard cancer. And of course, we couldn't not prepare and distribute together with all the maximum experts, of course, in nutrition, in oncological nutrition. We couldn't avoid to publish this booklet, which is the first main booklet required from patients to IMAC, which is the nutrition of cancer patients. This is how IMAC distributes all the information for empowering cancer patients about all the aspects about quality of life, with particular reference to nutrition, because we have a national helpline, and also, this. If you see this map, there are more than. This is not an updated map. I'm sorry, I just saw it. In this moment, we have more than 50. Information points all over main cancer institutes all over Italy, where our volunteers that are, of course, are very well trained, can help cancer patients and their families to be informed and so to be very much empowered about all the aspects of quality of life. And of course, again, the booklet is the most required. And then, okay, I go just forward. FAVO, going back to FAVO, FAVO, of course, is very much focused on advocacy in lobbying with institutions. And again, with all stakeholders which work every day with passion in oncology, we from 16 years, we published this very important report on cancer disparities. And every year, we insert within this report, which is sent to, presented in the Italian Parliament, and then sent to all stakeholders possible, in order, again, to advocate and to make people understand how much important are nutritional aspects for cancer patients. And so we send, this report to everyone. And so you see here, of course, I'm sorry, this is Italian, but we speak about nutritional emergency. We speak about the chart of rights of cancer patients. And this what creates? It creates a great collaboration with institutions. In fact, in 2017, FAVO has been invited by the Italian Ministry of Health to contribute to work on nutrition pathways for oncology patients. This is the output of this very important meeting in which the Italian Ministry of Health have called to an action to all stakeholders in oncology. And so this is a very important document, which is a guideline to be sent, of course, and to be followed for guaranteeing nutritional pathways for cancer patients all over Italy. Meanwhile, we were continuing showing and representing difficulties on nutritional and to access to nutrition in all over Italy, again, in every report that we make. And then, of course, we also tried to ask to the Italian Ministry of Health, okay, how is the situation? After that, we produced all together those guidelines. What is happening in the Italian regions? Do Italian regions really guarantee this nutritional support? And so Ministry of Health has sent this letter to all the regions. Not so many replies have arrived. Of course, we have some excellent situations overall in this last year, which guarantee really and concretely an adequate nutritional support to cancer patients really in cancer institutes, while we have many regions in where we always denounce that cancer patients are not even weighed while they have to calculate, the chemotherapy. So this is a big disparity that is happening in Italy. Again, have you seen, we never stop. We are really, like a tractor. We go every year, and so every year we present all also the new groups, because, for example, we have created a very important alliance with the Alliance Against Cancer, which is the network of all research institutes, cancer research institutes all over Italy. And we have produced this very important position paper on survivorship care and nutritional support. And again, if you see here, I'm sure that over there are our friends from Simpe, so Caccialanza and Pedrazzoli from IOM, all the group with whom we always work. And we again presented this specific chapter on fake news, because again, still in Italy, there are so many fake news on nutrition. That's why we have decided to work to empower even more our cancer patient organizations federated to us. And for example, we have created this very important group, which is Pavo Donna, the group created by all women that every day are involved in helping cancer patients to deal with women cancers. And so if you see in the decalogue, there is nutrition. So again, we always stress the importance of nutrition. And again, we really believe that training is fundamental. So we have created from some years this very important tool that really is one of the most appreciated tools by our cancer patients organization, which is a caregiver academy. We just provide to caregivers, of course, together with the main experts every year on different issues. We provide cancer caregivers with specific information regarding, for example, nutritional support. Because, of course, I become a caregiver from one day to another, and I don't have the good know-how for helping, the person I follow, the person I care for, with the appropriate nutritional help. So this is something that we organized, and this has been so important. This is just those are just some examples of the questions that our cancer caregivers have asked. Have you seen again? Does sugar feed cancer cells in advanced patients? Is nutrition important for maintaining a good quality of life? So we are again seeing that. People don't know again that nutrition is so important, that nutrition is part of the cancer pathway and of the treatment. So there is so much to do. We do all this together with those are the logos of our organizations, which are federated with us. And together with all, again, this is something we always stress because I think it is our power, because cancer patients, together with scientific societies and with the institutions, I think that this creates the only solution for really empowering cancer patients and solving some of their important problems. Thank you very much.
Thank you, Laura. Thank you very much for this very nice talk. I would like to ask you to remain with us until the end of this session to have some discussion all together. Thank you. Thank you. Now, it's my real pleasure to introduce to you Dr. Ugo Della Marta, which is General Director of the Directorate for Hygiene, Food Safety and Nutrition of the Italian Ministry of Health. We are really happy and honored to have him here, which means that Ministry of Health is really involved in this battle against malnutrition, and we are eager to hear about getting grip on nutritional care at a national level. Please, the stage is yours.
Thank you very much. It is an honor for me to be here today. And let me, first of all, thanks to the European Nutrition for Health Alliance, to the Professor Ljungqvist, to Professor Lezzo, the Italian ONCA team, and Professor Lezzo has invited me, if I remember true, in the Congress of SIMP in the last October in Rome. It's a great pleasure for me to discuss in this magnificent venue in Turin, in the Teatro Regio, the issues about the malnutrition. And the choice of Piedmont region is not casual for me, because for my perspective, from my central perspective, in the Piedmont region, were implemented the better practices, I think, in Italy. And let me to thank also to Professor Pezzana that have collaborated with the Ministry of Health as long time. And what we talk about in this presentation, a focus on the childhood overweight and obesity in the countries of European Mediterranean area, and particularly in Italy. A focus on the public health policies of our perspective of Ministry of Health, and a couple of minutes about two projects which we have implemented in Italy to spread the Mediterranean diet as a good partner of diet. The Arianna project and SDM project. Let me start with some data. Unfortunately, the adherence to the healthy partners in our country, and also it is a paradox, but it is so, and in the Mediterranean basin is not so excellent. According to WHO surveillance, the countries in the European Mediterranean area show the highest prevalence of childhood obesity and overweight among the countries participating to the surveillance, ranging from 38% to 47%. In the graph, the next graph, in this graph, extracted by the report of the WHO on childhood obesity and overweight, we can see that Italy is in the third place for the prevalence of obesity and overweight. And the paradox continues that because the third places are of countries of the Mediterranean area, in particular Cyprus, Greece, Italy, and Spain. Over the last 20 years, there has been a dramatic increase worldwide in the number of individuals affected by the so-called metabolic syndrome, a condition which sees the random association of at least 3 of the following 5 risk factors for diabetes and cardiovascular disease. We are in a nutritional transition. This is the paradox that with the policies, the policymaker in this field have to face, I think. An increase in income causes the progressive disappearance of hunger and slow decline in mortality, but with the introduction of free and disordered eating habits. Changes in diet and sedentary lifestyle led to emergence of obesity and other nutrition-related pathologies, with an increase in the prevalence of disability. Over time, we observe an inversion in the distribution of nutritional problems, with a relative change in the incidence and risk of nutritional diseases, with a direct about 30 years. The opposite paradoxical, hidden and often underestimated problem has also existed. The state of malnutrition by default that characterizes patients hospitalized in hospital and care facility. The nutritional transition of the food system in modern society affects both richer and developing countries, with a strong environmental, social, and economic impact, worsening the collective health status and increasing the risk of malnutrition and the development of non-communicable diseases. More aware and sustainable policies are therefore necessary, starting from the production and transformation chain of food, up to influencing the food models underlying collective health at the global level in the so-called farm-to-fork path, The solution cannot ignore two premises. Think globally, redefine and clarify means and professionalism capable of collaborating at a preventive and clinical level to identify strategies capable of intercepting the needs and the requirements to fight the paradox. As Dr. Pezzana in his presentation said very well before. These evidences are confirmed also by the International Institute for Health Metric and Evaluation. This institute, as you know, funded by international donor as the Melissa and Bill Gates Foundation. Another was based in the Washington School of Medicine, and in one of his report, there is evidence that unhealthy dietary risk, high body mass index, and malnutrition are in the top 10 risk factors for the global disease burden. Our task as an institution is definition of strategies and programs to support the application of evidence-based preventive strategies with a specific focus on healthy diet. And we know that policy choices have reason to exist if based on technical scientific consideration. And it is important some events like this to discuss for the policymaker, for the manager of the health system to have information to implement aware decision. What are we doing in Italy about this? We have implemented in the past, in 2017, a working group named TASIN, working group for promoting healthy aging through nutrition, named TASI, Tavolo Tecnico Sicurezza Nutrizionale. This working group includes both the institutional and scientific sector and has been established with the aim to implement policies to address healthy diet and develop guidelines and training programs to integrate nutrition assessments, counseling, and intervention into routine care for the elderly. Collaborate with stakeholders, other government agencies, no-profit organizations, food industry, stakeholders, and academia. Suggest any useful nutritional strategy to be provided to the political body. This slide you can see all the components of this working group. At what Ministry of Health, my directorate for food safety and nutrition is working towards. We are working for research, investing in research together with the Italian National Institute of Health to better understand the nutritional needs of elderly and to develop innovative strategies for promoting healthy aging through nutrition. In innovation, developing guidelines on nutrition and sustainability, environmental, technological, innovative, sociocultural, and demographic through the TASIN, this working group. Progressing health development and cohesion plan to create an action program to combat malnutrition in all its form and to disseminate the principles of the Mediterranean diet. Another issue I think that was underlined by Dr. Pezzana, it was important, the strict relationship between the health of the environment and our health and the food. Food environment, food choice. The ministry has worked with food industries. The implementation of policies for correct dietary styles and food balanced in its components cannot be achieved effectively without the contribution of all the players involved within the overall system, not least the food industries. The food industries in the last 15 years has improved the nutritional characteristics of over 4,200 food products and reduced the portion sizes for another 3,600. So it has become a partner in finding solution to the problem, in the awareness that health is linked to correct lifestyles, nutrition, quality of food, portion size, and frequency of intake of certain foods. Then our policy in the education in school age. As an institution, the ministry has the task of encouraging the adoption of healthy and sustainable diets by helping consumers to make more informed food choices through food education, starting from the childhood up to the adolescence. In this regard, the Ministry of Health has funded a series of scientifically based projects in recent years for Italian schools, carried out in co-working with the Italian National Institute of Health, and Italian schools abroad, carried out in cooperation with the Italian Ministry of Foreign Affairs, the Istituto Superiore di Sanità, and also the ISL of Turin, with the collaboration of Dr. Pezzana, with the aim to cross national borders. SDM project. Some of our publication, informative leaflets that we have published as a result of the work of the working group named TASIN. Another important issue is our intervention of the collective catering, as Dr. Pezzana said in his presentation. We have implemented the guideline for schools, hospitals, and healthcare catering. We think that meals provided by the collective catering service can be a great opportunity, as it can play an important educational role influencing individual and collective food choices, with positive effects on the habits, the practices, and the sustainability of eco-agro food system. While having to respect the taste and the expectations of users, it is an indispensable tool in the prevention and treatment of diseases related to an altered state of nutrition. This is the guideline that I mentioned before, and also we are working on the correct information to citizens. Ministry of Health every year launches campaigns to educate the public, especially the elderly, about the importance of nutrition in healthy aging through institutional website, informative leaflets, traditional and new media campaigns. We remain convinced of the central role in prevention of the direct involvement of citizens that need to be main actors in the health system. Finally, in order to guarantee continuity of all these activities mentioned, our director organized in 2023 the National Conference on Nutrition, the first National Conference on Nutrition, at this conference professional members of the main scientific societies, official of the Ministry of Health, Agriculture, of the region, of the National Health System, of stakeholder of industries, farmers, and discussed for 3 days. At the end of 3 days of an intensive work, it was adopted a statement in the shape of a decalogue that you can see in the next slide. And I think that in this statement we can find what the previous work of Tazin has implemented. Prioritize nutrition for well-being, promote the Mediterranean diet, ensure uniform nutritional services, because we have a geopartized situation in Italy, some region with a good organization from the prevention to the hospital, and some else not in this good situation. Combat malnutrition and chronic disease, collaborate across the food chain with the industry and the farmer organization, fight misinformation, another issue I think important in the era of internet and Google, teach preventive nutrition in the School of Medicine, and educate early on healthy eating. It is important. One of the conclusions of the statement of this conference is to introduce in the program, in the plan of the primary school, okay, I'm go to the end, and also monitor school meals and reduce food waste. 2 couples of minutes on our organization of the ministry. We in our directorate, our organization, there are professionals as medical doctors, veterinarians, chemists, biologists, and pharmacists that work in, I think, in integrated and multidisciplinary manner for a One Health approach. And to arrive to the end of my presentation, one couple of words about our project on the Mediterranean diet as a model of traditional healthy and sustainable diet for healthy nutrition in adolescent. And we are promoting the STDM project. It's a project where we have invested in the school abroad, the Italian school abroad in the world, not only in Europe, but also in the United States. This is the slide on this project with some promotion of health of young Italians abroad and recall their tradition, prevention of chronic or non-communicable disease, intervention in schools, international comparison. And let me conclude with the food for thoughts. We are working for structural intervention and dietary habit strategy considered priorities in order to provide accessible the traditional diet, such as the Mediterranean diet. We know that healthy diet safeguard both the individual well-being and the cost for the health systems. We are in continuous contact with scientific sector to implement a monitoring system of the action and policies based on specific indicators that could guide policy making. We are convinced that healthy diets and healthy aging cannot be separated by the concept of circular health. As an institution, the Ministry of Health has a clear idea of the link among environment, animal health, and food safety. Be aware that a treat to one of the above list aspects might have a significant impact on all the others. In our country, the new composition of the Department of One Health of the Ministry of Health, merging food safety, animal health, and healthy lifestyles, highlights that we are going in this direction, in this, I think, right direction. We are working together. Healthy diets for healthy aging are a multifactorial process and need a multi-sectoral approach involving institutions, scientific world, food industry, stakeholders, and academia to develop and implement comprehensive strategies for promoting healthy aging through nutritional policy. And for final, let me to thank to my collaborator of the office 5 of the directorate that I have collaborated to my presentation. Thank you very much.
Thank you very much for this talk and for the encouraging messages you gave us. Now we need newly some help from technology to invite on the screen the next speaker, which is Dr. Francesco Branca, connected with us. Hello.
Good afternoon.
Hello, welcome. Dr. Francesco Branca is the Director of Department of Nutrition and Food Safety of the World Health Organization. We are very, very honored to have you here today. He is going to tell us about global insights into disease-related malnutrition, understanding the worldwide impact. Thank you.
Well, thank you very much. I really appreciate the work that the Optimal Nutrition Care for All initiative is doing, as well the European Nutrition for Health Alliance. And I particularly would like to thank Professor Leser for this invitation and also for her flexibility in accommodating the way I wanted actually to present this to you, and for being flexible with the title of my presentation, which actually I twisted a little bit. And please let me know if you can see it. Can you see the main? Okay, no, you don't see. You see the. Okay, try again. Okay, that's better. Oh, but you see unfortunately, you see my the notes that doesn't come to the full screen, correct? Yeah, sorry. Okay. All right. So you still see the unfortunately the notes. But apologies for that. Good. So I changed a little bit the title, Professor, if you don't mind, and I really would like to tell you about how to make our health systems nutrition friendly. And I'd like to start where Dr. Della Marta left you. He mentioned this source. He mentioned the analysis that the Institute of Health Metrics and Evaluation does about the risk factors for the global disease burden. These are the data on deaths, and as you can see from the slides, as Dr. Della Marta was saying, the dietary risks are among the top 10 risk factors for the global burden of disease. 8 million deaths every year are accounted for by dietary risks. But we need to add to this also the additional burden of disease coming from multiple forms of malnutrition. First and foremost, the high body mass index, overweight and obesity, 5 million deaths every year. And on top of that, additional 3 million that's coming from maternal and child malnutrition, including poor breastfeeding. So altogether, this is a massive amount. This is a massive burden. It's about 1/3 of the global burden of disease. And if you look at the disability-adjusted life years, if you look at basically the life that people live with disability resulting from malnutrition, that number is even greater. So we're talking about millions and millions of life that is not really lived in the full health and function. I said I wanted to tell you about health systems, and of course I'm talking to an audience which is looking at how to deliver services. And I'd like to have a disclaimer. My team and WHO does not work as yet in providing guidance on how to use diets to treat diseases. So we've been mainly focusing on the prevention of diseases, infectious and chronic diseases. So having said this, we have been looking at what kind of nutrition interventions we can provide in health system, across the health systems, to address these multiple forms of malnutrition. And what we can do is certainly, first of all, have a good diagnostics in place. And growth monitoring is still the basis of promoting healthy growth and preventing malnutrition. But the screening of obesity is something that we are now seeing is absolutely critical, given the incredibly large and quick growth of the epidemic. But then, of course, we want the health systems to manage nutrition disorders and to do something about it. And health systems are able to address wasting, the low birth weight of infants, the life of patients living with tuberculosis or HIV. They're addressing obesity, and they are responding to vitamin and mineral deficiencies. Health systems can also provide counseling. And so behavioral change communication, counseling on breastfeeding, complementary feeding, healthy diets. Health systems can support women to breastfeed and can prevent vitamin mineral deficiencies through the administration of supplements, particularly vitamin A, iron, and folic acid supplements. This is somehow the package that we define of essential nutrition actions. So that's something that really should be provided by all health services in primary healthcare, primary care. But what is the reality in the world? The reality in the world, and unfortunately, we don't have always good data about the provision of services in the health system. But in primary healthcare, in the analysis we have, and it dates back a few years, is that not more than a third to half of the world population basically have full coverage of essential services. So we have a large number of people which do not have services. And looking at the left side where you see the graph, only 71% are children are weight when they are born. And this is in the face of 78% of the children that are delivered in health facility. So although the service could be there, it's actually not implemented. But even more remarkably, if you look at the third graph, the third bar, 78% of newborns were assisted by a neonatologist, but only 57% were receiving support to initiate breastfeeding early. Or even if 67% of women receive antenatal care visit, only half of them, 33%, received an adequate number of iron and folic acid tablets. So somehow, nutrition services are left behind, are forgotten by the health system. Why is that? Certainly, one of the elements is the capacity of health workers. We have calculated that a good number of nutrition professionals, and here I'm bringing everybody, It could be doctors, it could be nurses, it could be dietitians, it could be even community workers. But we need at least 10 health workers per 100,000 population. It's not a large number. But the baseline we had in the world in 2016, 2017 was 2.2. And you can see the different regions. In the American region, it seems that nutrition services are delivered. But even in our own, in this region, in the European region, the numbers are low. There's a large variability, but nutrition professionals are not there. So health workers do not receive adequate training to be able to deliver nutrition intervention. I would like also specifically to speak about obesity. Why is obesity not treated in primary care? And unfortunately, even in Europe, we have basically a large proportion of people who are diagnosed as being obese only when the consequences of their obesity develop. Obesity is often diagnosed by cardiovascular specialists, by diabetes specialists. And why is obesity not treated in primary care? Doctors say they don't have time or they don't have resources, but often, and about 40% of the cases, they don't know how to do it. They don't know what to say to the patients. Some cases, it's also depending on the patient themselves. And it says here they lack motivation, but often we've heard a lot from patients too that actually people living with obesity are discriminated by health workers. There's no equipment. I mean, often people with large weight have to be examined on the floor because the examination bed is not large enough. So we don't really have a health system which is capable of delivering health services. And talking about obesity, for example, WHO has developed a health service delivery framework for the prevention and management of obesity, in which we say there is an important role of primary care in the diagnosis and management of obesity, but obesity needs to be managed across the multiple levels. It needs also to be managed, prevented and managed through community-based care, through home-based care and self-management, and of course, in primary, secondary, and tertiary care. So there is a problem of resources. There is a problem of design of services that do not include nutrition services. I'd like to focus now on a couple of issues related to the hospitals. In this meeting, you are of course dealing a lot with what is happening in the hospital. I would like to say that one key thing that the hospitals could do would be to support the early initiation of breastfeeding, to support the establishment of exclusive breastfeeding. And this can happen if we have what we call the baby-friendly hospital initiative. The baby-friendly hospital initiatives require that 10 steps are established to successful breastfeeding. We need to have facility policies that stop the marketing and the promotion of breast milk substitute in hospitals. We should not see infant formula in hospitals. The hospitals should have a facility policies for the promotion, protection, and support of breastfeeding. We need to have a competence of staff to be able to provide support to women who want to breastfeed. And then a series of clinical practices, such as providing information to women even before they deliver through antenatal care programs, immediately postnatal care, the support with breastfeeding, not discouraging if they have, start having the risk of mastitis, having children close to the mothers in the hospital, teaching responsive feeding and not the timed number of timed breastfeeding opportunities, avoiding the use of bottles, and providing a system to prepare for women who want to continue breastfeeding at discharge. So we know that if we see this happening, breastfeeding rates increase. And still, you see from this graph that the percentage of births in hospitals and maternities designated as baby-friendly is still very low. I mean, only in the green, in the countries covered in green, you have more than 50% of the children who are born in those facilities. In Italy, we have probably less than 20% of the children who are born in facilities designated as baby-friendly. And this is actually something which also is a source of great discrimination, because often baby-friendly hospitals are in wealthier regions or wealthier neighborhoods. The other point I wanted to make about hospitals, it's actually sharing with you an initiative. You may already be familiar with it, but an initiative of the Canadian Malnutrition Task Force. Really, they've been working extremely intensively on nutrition risk screening, and really as a first element for the provision of dietary advice in hospital. I'm mentioning this particular initiative because the Canadian Nutrition Society and the Canadian Malnutrition Task Force committed to the Decade of Action on Nutrition, which is an initiative led by FAO and WHO, which has been going on for the last 9 years. We're in the last year of the task force, with the idea of recruiting other countries to do the same, to do basically the good screening and management of nutrition disorders in hospitals. But hospitals are not just places where you treat patients. Hospitals are places where a lot of people, staff, relatives of the people admitted. There's a lot of outpatients, of course. So it's quite important that all foods which is served, distributed in hospitals is supportive of a healthy diet. WHO has been campaigning to have good public food procurement and service policies for healthy diet. We actually use this term because we mean that, of course, healthy, we have nutrition criteria to say that, about free sugars. It's about quality fat, it's about reducing salt, it's about promoting whole grains and vegetables, and having water instead of sugary drinks. The public has a lot of power because the government funds buy this food, and in fact it's not just food but also the drinks, ingredients, meals, or snacks. And the policies should cover the entire process of purchase, subsidy, provision, distribution, service, and sale of food. And this can be done through policies, strategies, directives, legislation, rules, standards, or guidelines. And it can be more mandatory as well as guidelines. So this is an example of a nutrition criteria. I mean, we can use national or regional dietary recommendations. We can use the WHO nutrient profile models, our WHO recommendation on what is healthy diet. And just to give you an example, this is what the New York City does about public food procurement. And this policy applies to hospitals. They serve millions of meals every day. And, these meals are actually being moved to becoming much more supportive of a healthy diet. And I'd like to finish with this interesting concept, which is being actually developed in the United States, but it's becoming a global movement called food is medicine. Of course, we say that food is supportive of health, but food, as already many centuries ago, Hippocrates was saying, food can be used as a medicine. And I think that's also what this meeting is discussing. Adequate food and adequate dietary treatment can shorten the time in hospitals, can improve success of treatment, and it is to be medically tailored, but it can also be somehow prescribed to patients. And there is an accountability of the health systems, and there's a way that potentially health systems can leverage access to healthcare foods with different schemes to actually help people who need to stay on a healthy diet access that. But this is actually part of the pyramid. So this is in line with having government nutrition security program and population level healthy food policies and programs. So there's no discontinuity between what happens in the facility and what happens in the overall population. So my key messages are that certainly universal health coverage cannot be achieved without ensuring that everyone has access to quality nutrition services. And we need to do that to primary healthcare in the first place, but also at a secondary and tertiary level of care. Specifically, hospitals can contribute to address malnutrition and unhealthy diets by promoting, protecting, and supporting breastfeeding, by addressing hospital malnutrition, by performing nutrition screening, and by providing healthy diets to patients, staff, and visitors. Improved hospital nutrition can improve prognosis. This is like from, you see, a movement to actually not have fast food outlets in the hospital, which has been, in many cases, a way to actually support the finances of hospitals. Thank you very much.
Well, thank you. Thank you very much. If you can, stay with us some minutes more for the discussion. I would like, please, to invite on the stage the speakers, and on the screen the other two speakers, if possible. Well, the audience is quite silent. I hope it is for respect and not because you are boring or sleeping. Okay. Now, any question or comments for our speakers? I think we had some. Oh, please. Can we have a microphone?
Microphones?
Yes, thank you.
Well, while we're waiting for the microphone, maybe I can just start off a little bit. We have two people here on stage that have been working together. Yes. And I think that is a very good and important collaboration that you have been able to establish between the government and the professional. So if I just may start by asking both of you, what was the most important thing that you learned from the other one?
In this field, I learn everything because I'm not a professional in this field. I am a veterinarian. I have good collaborators in my directorate, as Dr. Pezzana knows, doctor, nutritionist, Dr. Plutino and Dr. Copparoni. But I think that in the collaboration between the central government and the professional of the national health system in our view, in our perspective, is important. We have a system in Italy, it is a federal system where the region has an active role in the healthcare, the main important role, I think. But at the national level, we can introduce guidelines. We can collaborate to try to improve what in the field that the national health system carry out.
A quick follow-up on that: how much of the basic knowledge that you needed in order to be able to move from your end did you actually get? Because I think this is, in many places, we need to help educate each other as well.
Yes.
Right?
Yes. It's so I have learned in these 2 years that I worked in this directorate many things in this field, and I hope that my contribution for my from my professional perspective, that is not this, but is important in the One Health approach, is important.
Exactly. And
well, I have to say I learned a lot. Just a few suggestions. Well, probably focusing on the framework is as important as focusing on the topic. But we have a lot of difficulties as professionals as focusing on the framework. They gave us really a very strong help in understanding how important is, I would say, the right visibility, the right network, something that alone as professionals we have a lot of difficulties in doing. So they really helped us for that. We learned a lot about the methodology of communication. I'm thinking, for example, of the experience we had together, the Expo Dubai, on the documents on Mediterranean diet. So, I mean, starting an international and quite challenging experience is something that you have to do with a very strong partner. So we learned a lot about that. And it helps us in understanding something that in everyday, I mean, working activity is difficult. We're working a lot, of course, for patients, for the institutions, for doing our best, but sometimes stopping and understanding what you are doing is as important as, I mean, prescribing therapies. So we must understand that this must become a part of our work. We are not wasting time, but we are using it wisely. So we have to counterbalance somehow, and sometimes I would say the pure work, the strong work, and stop, interact with local and central government. So they really help us. For example, also in publishing our data, our papers, what we do with our scientific dossier was very difficult to be done, I mean, with our local health governments. They have much more power in that, and this is probably the most important part of our experience with the ministry.
You are right, perfectly right. I think we must be not only hard workers, but wise as well, and to program somehow our challenges and our strategies all together, if it is possible. So, the question, can I gather the question from the audience, please?
Yeah, so, Nolanda van Waal from the Netherlands. Today we have our European elections in the Netherlands, but also we have Advocacy, a cancer-raising fund from a lot of Netherlands going up the Advocacy. But I have a question. So, Laura, you did a really good work for the cancer approach. So how can this innovative, what you did, coming to Europe broad? Because I think this was really, really good job what you done in this area.
Maybe Laura can tell us something about it?
Yes. Can you hear me?
Yeah.
Yes, sure.
Okay, yeah, thanks. Of course, we are already working within a European framework in general. And in fact, we are very much involved also in European projects. And before I forgot to say, for example, that now we are participating in this important project about prevention and about importance of lifestyle attention for children and adolescents, of course, with regards to cancer. And this is a very important partnership that we are having. It is a project that just started on last January. And now we are just doing a big survey with within 88 European countries in order to understand, because as always we before understand which is exactly the situation and then we try to act. So the thing that we do always, as I said, it is to work together with experts and with institutions. This is something that I think it's a model which is replicable and that could be extended also to other areas, of course, of intervention. We are very much involved also in with the European Parliament, with the European Council, where we try to participate and to give our feedback and to participate in order to be always, very much updated and also involved in all aspects that guarantee a better quality of life for cancer patients.
Yes, thank you. There are a couple of questions still. Yes, please, Professor Volpe.
Thank you. To Francesco Branca. Hello, Roberto Volpe from CNR and European Art Network. You spoke about the ban, the hamburger in the hospital, but also, I suggest, close to the school. But we know that it's no easy. There is always blackmail of we lose job, and there is some good example in the world. And if there is, how they reach it, and which suggestion you can give us? Thank you.
Well, thank you for the question. First of all, those examples are coming from the Anglo-Saxon world, where somehow food was used as a way to fund the hospital. So it's been a political decision by health authorities not to do that. So I think it's a policy choice. It's a policy choice. In terms of the policies that can actually shape that food environment, what WHO is recommending is a package. So we recommend to use the economic leverage, so have fiscal policies. On the one hand, taxation. We're actually about to launch the guidelines on taxation of sugar-sweetened beverages and food next week, but also subsidize the healthy food. So there's evidence that this is actually happening. Also food. Colombia is now taxing foods which are not supportive of healthy life. So that's one. The other one is information to the consumers. Education, of course, is very important, but at the same time, having a clear, easy to understand front of the pack labeling is really important, and regulate marketing food to children. That is absolutely critical. And finally, the public food procurement, which is, as you say, not just in the institution, particularly in schools, but around the institution. Many countries are doing that. There's actually urban policies that restrict advertising of unhealthy foods close to school.
Okay, we have a question over here.
Also, I'm not sure if I'm turned on.
Yes,
I'm turned
okay.
on. Declan O'Brien from the British Specialist Nutrition Association. I'd like to ask Dr. Branca if we should be, or if the WHO should be looking at infant mortality rates, stunting, wasting, and obesity in children at perhaps 36 months by country, and then looking at the causes. I would suggest that a one-size-fits-all doesn't really work, and that it would be much more beneficial for child health to address those issues in individual countries. Thank you.
Can I add another question we have from Mila and Lomer online, which is about the same thing from Dr. Branca. She said, what is WHO doing to address the issue of discrimination against patients with obesity in medical settings? So maybe he can combine.
Sure, no, it's an important question about how do we consider the causes that lead to increased child mortality. Okay. I mean, we know that about 45% of child deaths are accounted for by malnutrition. So it's an absolutely critical one, particularly in low-income countries, particularly on the two main causes of death, which are diarrheal diseases and upper tract respiratory infections. That period is absolutely critical for that. We have released, for example, clear guidelines on complementary feeding. So children should be breastfed for 6 months exclusively, then continuously breastfed for 2 years and beyond. But at 6 months and not earlier, we should introduce adequate complementary food. And we should have diverse food. We should give animal source food every day. We should avoid children to consume sugar-sweetened beverages and sugar. Sugar is actually very common in the diets of children in early ages. So that period, until the age of 2 or the age of 3, is absolutely critical. On the issue of stigma, yes, I mean, there's actually a global effort led by the World Obesity Federation and partners, that include WHO, on communicating better around obesity. First of all, we use what we call the first people language. So we don't see obese people. We see people, we say people living with obesity. And, we're trying to take away the responsibility from people living with obesity of the obesity. It's an environmental issue. It's often related to their that people's inability to live healthy lives, have access to healthy food, being adequately active. And then I think what we have to do is speak to the clinician and to the primary care doctor. They are the ones who, in the first place, need to welcome people living with obesity. They have to not stigmatize their condition, but actually encourage them and guide them into a recovery path.
Okay, thank you. We have some questions still. Yes, please. And another question then here.
I have the microphone at the moment, so.
Yeah, please.
Okay.
Okay. My name is Nicole Erickson. I'm from the German delegation from Aspen Society, and I am a clinical dietitian who also does a lot of research that's patient-oriented. And I sort of wanted to comment on the food is medicine pyramid, and also the whole all of the presentations that have come, because I think we need to differentiate a little more clearly at all levels. That there's a big difference of malnutrition in the sense of leading to obesity and in the prevention of cancer. And we also need to think of malnutrition in the sense of undernutrition when one is undergoing cancer therapy. And my experience directly from patients is that they often mix the two. They should not be eating salad and vegetables if they are undernourished due to cancer therapy, but they often take these recommendations, which are correct for the prevention. And I think it's up to us from all levels of communication to differentiate these two things more clearly and more adequately. So both at a societal level and at a patient level, this is more well understood.
Yes, you are right.
And
it's
it's shown in
very
the pyramid.
important comment. Thank you. Thank you very much.
Thank you.
We need the microphone from this side, please. Thank you. Is there only one microphone?
From Germany. I have a question for Dr. Della Mata. Thank you for your convincing presentation, but I just wonder why you, as a representative of the ministry, discuss obesity without mentioning any social cultural background. I think I can imagine that in Italy it's comparable to Germany, where obesity is also the prevalence of obesity is much, much higher in poor and mal-educated people, and where malnutrition can also be seen as not having enough money to buy healthy food. So can you comment on this? And you probably know also the American recommendation that the best way to prevent obesity is to change the district you live in.
Yes, thank you for the question and the comments. Yes, we know that the distribution of obesity is due also to the social class of the people. And now in Italy, also the distribution, as Dr. Pezzana know better than me, is the obesity is distributed unfortunately in the south regions of our countries. The south, this is the paradox, because as I said in my presentation, in the south region of our country are the cradle of the Mediterranean diet, and but we are working in this direction, and we know that it is also a social problem to face to improve the dietary habits of the people.
Okay, thank you. The last question.
Hello, Pavel Tesinski. I'm president of the Czech Society for Clinical Nutrition. First of all, thank you for the wonderful presentations. My question is, there is evidence between the sweet beverages or sugar-rich beverages and obesity. So I wonder if there are any tendencies from the WHO to reduce the amount of the sugar-enriched beverages, and there are some tools to reach the target, similar as it is with alcohol. What I'm meaning are the taxes. So is there any way, do you think, is there any way which may be feasible for this purpose? This is a question for the WHO representative.
Thank you. Dr. Branca, can you?
Yes, a brief answer. Thank you for the question. Yes, indeed, the taxation of sugar-sweetened beverages is an important means to do that. We now have over 100 countries who are doing it, but they're not doing it in the right way. So if the taxation is not adequate in terms of proportion, we need to speak about at least 20% of the value of the product to reduce the consumption. Another way is to actually have very clear labeling. Particularly in South America, the warning labels that indicate that a product is high in sugar are effective in reducing consumption. And of course, the marketing controls. One way we have seen that doesn't work is the replacement with non-sugar sweeteners. In the long term, replacing with non-sugar sweetener doesn't help weight control, can only maybe help in the short term. We need to reduce the sweetness of food, and we need to start that from very early in life.
Okay, if I could have the microphone. Well, we are here to discuss how we move information from science to policies to actually getting things done. And the key to all of that is to make sure that everybody who has a stake in this actually sees the same problem. So my question, and a quick answer from everyone who's been on the panel, is what makes you listen to the other stakeholders? What is the most important way for us to actually get the ear of the government and the ear of the professional from all the different stakeholders? If I could have a quick answer on that. Do you want to start?
Well, that's definitely a not scientific one, but we should focus on I would say the frailty we are experiencing, the frailty of the system, of people, of moods, of everything. So probably joining on that could be one hypothesis of solution.
Okay. Government?
Also for me, the exchange of point of view of the different point of view from the industry to the patients is I think one way for the solution of the problem.
So from the patients, what makes you interested in taking part of this, except for the obvious fact that you have a stake as being a patient? But what is the kind of information that would make you want to join and help out?
No, I can't hear you anymore. Sorry, could you repeat, because there's a problem in the connection. Could you repeat, please? Yeah,
we're just trying to figure out what is making you listen to government, to WHO, to the professionals. What is the key message? How should we be addressing you to get your engagement better, to get all your patients involved?
I just think that, as I said before, the key for solving problems is to sit together and to hear at all the problems from a different point of view. I think that this is a very important thing. For example, here now in Italy, we just have obtained a very important law which finally considers formally the role of cancer patients organizations that have to sit within, the important tables when we speak about health, in our case, of course, about cancer. This is something that makes the difference, because before it was just the cancer patient organization, at least in Italy, that was going, and knocking at the different institutions for being heard. Now we have obtained, thanks to this very important advocacy moment of FAVO to be formally heard. Now people have to, all different institutions have to hear really which are the real needs of, in our case, cancer patients. Because we always say, how could you think about something without considering, before hearing the real needs of cancer patients? So this is what really makes the difference. And this, important law that we have obtained, I think that will make the difference.
Okay, well, thank you. I think we've been hearing how the Italians have been able to solve many of the obstacles, actually, in getting communication across. So I think that's wonderful. But we also like to, yeah, we'd like to also hear from the WHO. How do we catch your interest in undernutrition, and who do you want to talk to primarily?
The interest is the health arguments, well-being, but also the economics and social and security, world security. The unequal world is an unsafe world. And the cost of malnutrition is enormous. Only obesity is 2% of gross national product. So we speak to everybody. We want to speak to everybody, but I think particularly policymakers have a great moral and political responsibility. So we listen to them in the first place.
Okay, well, thank you very much. I think we should give
you.
everybody a big hand.
Okay, we went through, I think, successfully this first part of the day. Now we have optimal lunch for all. Okay.
And we will be back a little after 2. And for those online, please come back.
At 10 minutes to 2 p.m.?
No, a little after 2, right?
After 2?
Yeah, I think we're a bit late.
Oh, yeah. Okay.
Sorry, moderator.
10 minutes after 2.
If I can just add, do you?
Yeah, please.
Can you?
Okay, just a moment.
Can
please.
you stop just a moment?
We just wanted, to share with you for a couple of minutes
some details about the optimal lunch.
The philosophy of the optimal catering for all. Tonight at dinner, we will have more time to discuss and understand, but just a few keywords in order to try this gastronomic experience with a few.
And I'm just going to start off by showing a couple of slides. If we can get the slides. Yeah, so this is really what we're trying to do within the European Nutrition for Health Alliance, is trying to take the science and translate it into policy. That's one of our main topics here. And we believe that, I think we all can agree, that undernutrition needs a place or a seat at the EU health policy table. The way that we do these things is we work with, among others, the European Commission. We have been publishing papers on this topic. We brought it to the attention of the Commission, and we've also had policy documents published with them, so I think, and endorsed by them. So I think that is one way that we can move ahead. And of course, the reason that they are listening to us, and it's all about really communication and having the right people around the table, is that we have all these phenomenal and dedicated organizations that are part of this whole project and supporting it all the way through. And I think that is really the key. That's what opened the door for us many years ago, and that's still, I think, one of the most important aspects of this whole thing. Not only does it help open the doors, but it also helps spread the word in all different directions where it's needed. And this is how we look at how we can change things at both the EU level and at the national level, because they interact. So it's like a a circle that keeps, or a lying down 8 that keeps going round and round. In order to get traction at the EU level, it's very important to have different countries come with the same idea to push it at that EU level. And once you can have it anchored up there, it will then spread to all the other countries as well. And this is where we do all these different things. We try to get involvement from all kinds of members at the EU level, project partners. We try to get involved in different EU projects, like we had when EU4Health was there, we had EU4Nutrition as part of that. And we were involved with healthy aging as another example. And we do things by sharing our experiences from all these different places. And many of you have helped share those experiences with good practices that are all available online, and they're actually being used as well. So it is really worthwhile. And then we have the ONCA conferences, like this one, and the policy seminars. And I think altogether, this helps to keep this movement going all the time. And of course, we're here today, which is one of the main things that we're doing over the year. So today we have these lectures and discussions. Tomorrow we'll have the workshops, which is going to be much more interactive, I think, and they're always a lot of fun. So we will continue to enjoy ourselves here. And now it's my pleasure to introduce two very close collaborators, both members as trustees of the ENA board. And I'll start with Annemieke van Ginkel, who is also the president of the European Federation Associations of Dietitians, EFAD. And she will start talking about collaborative initiatives, declarations strengthening the partnership in WHO Europe. So please, the floor is yours.
So thank you, Ola, for the nice introduction, and also Rocco to share this with me. It's about a collaborative initiative and declarations in the WHO Europe region. And EFAD is the European Federation of Associations of Dietitians. And ESPEN, of course, you know all about ESPEN. But for EFAD, it's very important to be here and to be a part of a multidisciplinary approach, because you can stare at your belly and think you are doing the good things for dietitians, but we have to share this and we have to work together and be a part of an integrated approach. So that's what it's about. I start with some important milestones for EFAD. And being a member of a board of directors in the European Nutrition Health Alliance is very important, because there are other partners and we can collaborate with them on an EU level. Partner in the ONCA initiatives, also our members became partners. As today there are many dietitians from the Italian association, and it is important to work together on tackling malnutrition in Europe, or undernutrition. In 2018, we became a non-state actor member of the WHO Regional Committee. That means that we are allowed to be at the meetings, but not speak at the meetings and not vote. We can have position statements there, and we do that. We do that on different topics, on primary care, but also the importance of nutritional care. And I think it's difficult to really address what we think is important. But if you don't be there, then there's nobody seeing you. So for us, it's very important to have a good message there. And we always repeat on every European citizen should have access to the right and proper and safe nutritional care. So that's what we are repeating there. We got some invitations to meetings. I will show that later. And in 2020, we were happy to have an agreement on collaboration with Aspen. And Rocco was very open to that. And the aim is to strengthen the collaboration and the working relationship, but also to invite a dietetic workshop in workforce in working groups on new guidelines or reviewing new guidelines, and of course knowledge exchange at Aspen and at the EVAT conferences. So a very important one is, I think, is in 2022. The Vienna Declaration was launched at the Aspen Conference, Nutrition as a Human Right. It's such a strong document, and I think we should all use it in Europe and constantly bring it under the attention. And at that moment, we thought we were thinking about in EVAT about to have a resolution in Europe to have something signed by all our members, and that's the Budapest resolution, and it's about the dietitian's role in supporting the human right to safe and appropriate nutritional care for every European citizen. And I think we can use this document for several years and come back to it, work on it with our own workforce, but also with you in this room. The spin-off of the EVAT Budapest resolution was a meeting with the FLO, but also with Hans Kluge from the regional committee. He has fortunately a niece who is a dietitian, so we immediately we connect to each other. And this morning we had some examples from how to relate to a politician. And I think if you know that kind of small things of each other, you can relate to each other and you can really connect. And of course, we had a meeting with Stella Kyriakides, and and then maybe you asked to me, what was the impact? I don't know. But I think it's important to relate to these people and really get your message there. And hopefully, maybe in 5 years, you get it really on the agenda. Because, we saw from Mr. Branco that he had a lot of documents produced in the WHO about nutrition. But in the regional committee meetings, it isn't addressed there. So I think it's very important for us to stay alert there and having this message there on the table. EVAT was invited to Kazakhstan in 2022 on the brief intervention in primary care. Primary care is a topic in WHO, and we are also focusing on this in EVAT. And also we are talking about with Aspen how to relate to that and how to really get some changes there, because every health system is another one. So we can't just move a blueprint to every country. No, you have to really dive into the country's health system and see what you can do there. Also, our executive director, Wieneke Remijnse, and Rocco were at the nutrition capacity meeting in Tajikistan. And it's about education of other professionals, but also about building capacity in these countries, also important. Several strategy meetings. I think you can read it, and it's important to be there and to have this prepared for yourself and to have a very clear statement there. And of course, also within ENA, we had a thematic network, and it was about nutrition, cancer care. It's really important, and I think also Ola mentioned this paper, and it's important to have this on this level too. Okay, I will give the word to Rocco, but I want to address some call to actions. I think that it's very important to have integrated multidisciplinary care paths for every diagnosis. It should be an integrated approach, not only dietetics own nutrition, it's all about us in nutrition. Patient care, this morning Robert Green was in the meeting and he said to me, Annemiek, last year we were in Amsterdam, this year we were here. What is changed? And I think we should try to keep that and to get a hold on it. What's changed next year? If we are in another country, maybe in Athens, I think that's very important too. So every European citizen should have access to safe and appropriate nutritional care. That's our message, and we are keep banging on the door. So, Rocco, the floor is yours.
Well, I'd just like to briefly introduce Rocco. I think at this point it's good to also remember that the European Nutrition for Health Alliance was actually initiated very much by ESPEN, by Claude Pichard at that time, who was the chairman, realized that there are certain things that we cannot do alone. We will never reach the people that we want to reach if we're just on our own as a professional society. And that was the beginning of the stakeholder organization. That was in 2005, wasn't it, if I remember? 2004, yeah. So it's 20 years. And I think just what we're seeing today with the chairman of ESPEN, which is now the world's leading clinical nutrition organization. The chairman is here to tell us about collaboration and working very closely with the dietitians. So Rocco, it's a pleasure to give the floor to you.
Okay, thank you. Thank you very much, Ole. Well, thank you all. I really appreciate the invitation. I appreciate being among so many friends and stakeholders. And I think that I need to thank Annemiek because she clearly made it very clear how important it is for ESPEN to collaborate, not only with IFAD, of course, but particularly with IFAD, because I think it should be natural, and maybe this is something to think about, that we are talking how good it is to establish these collaborations, but and that sometimes it's not so obvious and natural to proceed. You need to talk, you need to write some memorandums, you need to write some papers to make it happen. So that's also part of the message. Annemiek said it very well already, some of the initiatives that we have been doing together. This paper, I really need to thank Zeljko Krisnaric, the president, I think, of the Croatian Clinical Nutrition Society and a European leader in our field, and many others that were involved. It's one part of the picture. Of course, bringing primary care as a partner, a stakeholder to our claim for optimal nutritional care for all is quite important. We also heard Francesco Branca before from WHO. But I thought, okay, I will try to, in a few minutes, since the focus is on WHO, if I understand correctly, to make a short story of how we were trying to focus in the last 5 or 6 years on how could we make disease-related malnutrition and optimal nutritional care for the patients a priority also for WHO. This is a paper that it's a picture that comes from many, I think, WHO booklets, where, at least to us, it seemed a little bit too obvious that most of the focus is really on undernutrition and starvation and poverty around the world, which is really, of course, a tragedy and very important, but it's not covering all the, let's say, steps of what we are considering the challenge of malnutrition. Disease-related malnutrition is clearly a priority that might have been a little bit underestimated in this agenda. So this is a story of the strategy that we tried to put together. It started a little bit serendipitously, I think they said, with a serendipitous meeting at the Obesity Congress in Glasgow in 2019. And that's when we connected with a couple of people from the
prevention of non-communicable diseases offices, which also covers nutrition in WHO Europe, by the way. Dr. Branca is at the global headquarters. And then we thought, okay, why not try to establish this connection and invite these people to our Congress? Long story short, João Breda and Kremlin Vikramasinghe, they came to Krakow in 2019. I think it was very timely because you know what happened a few months later, and I will get there in a few seconds. We also had the time to meet in Moscow to establish a sort of a informal memorandum of understanding. I think they closed their office there, sadly, due to the obvious reasons that we all can imagine. And we started to think about how can we collaborate, and we wanted to push the disease-related malnutrition agenda. They were on time to meet us in January 2020. That was really a few days or a few weeks before the COVID pandemic blew out in Europe. And we established this connection. With the COVID, of course, things went a different way, but it also became an opportunity because when Espen wrote this paper on nutritional care in COVID-19 patients, they were very interested to collaborate, and we put them together in the team, and they were very happy about it. So it really helped to establish the connection and to make maybe the first example of how in WHO papers, this became a WHO paper, the importance of nutritional care for sick people, in this case a very special situation, became for them an official message, which is not, again, something to take for granted. And then we established a call for papers in our journals, another important tool to strengthen the cooperation. And we had many papers submitted to Clinical Nutrition and Clinical Nutrition Espen on the COVID topic, and we wrote a commentary on that, where this picture, for instance, was included and signed off again by our WHO colleagues on the importance of screening, diagnosing, and treating malnutrition in COVID patients in this case, in ICU, in the wards, and also after the disease. So I think this was, again, a tragedy, but an opportunity. In the meantime, virtually, we started collaborating on several projects. This is also, of course, with IFAD, with the Brief Intervention Manual for Primary Care, and Matthias Pirlich was our, let's say, delegate. We, together with IFAD, were able to push for some concepts to be introduced, even in primary care agendas, to include, for instance, screening tools. We know NRS, MAST, and they were actually mentioned in this booklet by WHO, which I think is quite important. We also wrote a commentary, and again, they were very happy to collaborate. So building collaboration, building personal connections, building trust, and showing that we can deliver, so we hope that they can also deliver. I'm sorry, but this is also part of the process. Another project was the report of the WHO Europe Regional Office on obesity. Of course, obesity, we know, it's prevention, it's diet, it's lifestyle, but we wanted to make the case that also malnutrition, undernutrition can be a part of the obesity picture. So sarcopenia is actually included and mentioned in this booklet, I believe, for the first time. So we were able to maybe push another case there. And tuberculosis, this was an invitation that came from WHO. They said, okay, we need to write a position paper on tuberculosis, the importance of nutrition, and we took the opportunity. I want to thank Johan Okenga and many others, writing this position paper, making the case that malnutrition is not only a risk factor for tuberculosis, but also an aggravating component of the disease. When patients become more malnourished, they become more sick, and the prognosis gets worse. So this actually has become another message from this paper, and I'm happy to show that just a few weeks ago, WHO has published a joint fact sheet where their logo is actually with our logo here on the importance of malnutrition diagnosis in TB patients after the disease is established. So not as a risk factor, but again, as a prognostic factor. And I think that's also a nice message. So we make it short. We started regular collaborations. We had joint sessions at our Congress since 2020, actually. WHO has participated in our Malnutrition Awareness Week initiatives with videos, with messages. I think that they have become more and more involved in our topics, and hopefully we have also become more and more in theirs. Annemieke mentioned the importance, and I think it's difficult to overestimate the importance of the Vienna Declaration, where ESPEN, EFAD, and so many other national societies established or launched a campaign for the recognition of nutritional care as a human right. I need to at least acknowledge Diana Cárdenas for her key role in promoting all these initiative since Latin American's declarations a few years ago. And I was very happy that Kremlin Vikramasinghe from WHO Europe accepted to be one of the speakers in this very solemn session in Vienna, and I think he said very meaningful words about the importance of disease-related malnutrition there, and that was actually only less than 2 years ago. In September 2022, following IFAD's steps, let's say, we became also non-state actors in WHO Europe, and actually that opened the door. I don't have the time to go into details with that, but together with IFAD we submitted a couple of statements on the importance of nutrition in primary care in 2023. We were introduced only a couple of years ago, but we tried to be active, so we attended the Israel event in 2022 and the Kazakhstan event in 2023. And I think I would like to spend the last couple of minutes on the process that has started in Kazakhstan, where we tried to bring the topic a little bit higher on the official agenda of WHO. And to do that, this we learned from the office, they say, okay, we need states, we need governments to make the statements that disease-related malnutrition is important, so that we can promote it on our agenda. They cannot make changes in policy. WHO cannot promote policy changes. This is a government action that happens in every country, in every region, and sometimes, unfortunately, that's very complicated. Italy is not a federal state, but for healthcare it is. Germany is another example, and so on. And so they said, okay, can we get something written from some state, from some government, to Kazakhstan to start the process of making it official on our agenda? And I think that a crucial role was again played by Croatia, Zeljko Krisnaric. Of course, some of us are better connected with our governments, some of us are less connected. I think Zeljko is a very important player in Croatia in this field. And we were able, as you see, Croatia submitted this statement which said, okay, in older adults and in all persons living with disease at any age, prevention, diagnosis and treatment of disease-related malnutrition, etc., should be considered a strategic goal in healthcare systems. And again, maybe I'm overexcited about it, but discussing with our WHO colleagues, this seems to be an unprecedented statement from any government in WHO Europe. So this opens the door to something that is hopefully underway to make the process a bit more official and to open more doors in the WHO communication. Another fact sheet was prepared as a follow-up this year, and again I need to thank Diana Cardenas. This came out a few weeks ago. Again, WHO and ESPEN logos are there, and I can tell you that this is more or less our statements, our claims, our hopes put down on paper, on screening, diagnosis, treatment, and everything, under the WHO umbrella. So I think that this could be considered maybe a tool for all of us that are trying to convince their policymakers of the importance of disease-related malnutrition. A time for action is coming also for WHO Europe, which I think is hopefully something meaningful. And to finish, to let's say, summarize and make maybe a new start with a more official, again, government level initiatives in Milano in a few months. We will upgrade our usual, traditional now ESPEN WHO joint session to a plenary session where WHO has invited 5 ministries of health. There will not be the ministers there, but 5 ministries. Again, Croatia, France, Italy, Moldova, and Tajikistan. I think they were discussing maybe Denmark, but this is not official yet. These countries have accepted. So we will have, I hope, very meaningful statements about the importance of disease-related malnutrition in Milano. So I hope that all of you will attend, and of course, many more. So I think that, again, the road will continue, of course, and definitely this is not enough. But I hope that at least we are able from now on, and maybe Francesco Branca also mentioned this morning, to count on another important, very meaningful and influential stakeholder to be structurally connected with documents, with commitments to our, let's say, fight or battle or claim for optimal nutritional care for all. Just to say with one more step, what I think is the call for action could be let's work together, let's use these tools, let's take opportunities. This started by chance at an obesity congress. COVID was another unexpected and tragic opportunity that we tried to take. So again, you never know where chances might come, but we need to be ready to take them and then build trust. And also sometimes we are thinking about maybe, let's say, institutions. Institutions are people, and so we need to build trust and good relationships. Sometimes if you meet the right people, I think that's worth connecting and building a relationship, because that can take you very far. The next step, we hope, in the next few months, will be to bring a new definition of malnutrition in the ICD codes that we use every day to diagnose malnutrition. I hope that maybe next year at ONCA, we will be able to discuss this new development. For the time being, I thank again EFAD, I thank ENA and ONCA for the invitation, and I hope we can continue to work together with these new items, new messages, and new stakeholders. Thank you very much.
Well, thank you, Rocco. I think you can see how these ideas are coming to fruition and being used as a strategy, and it's working well. I have, unfortunately, I have to tell you that Francesca Popucci, who was from the European Parliament Health Committee, was unable to deliver at short notice. She had to decline. But the good news is we have Tunde Kultai, who is from Hungary, but she's representing the European Patient Forum, and she will tell us about how this organization is also working within the European Union. And on top of that, yeah, you got what you need? Yeah?
I hope that it works.
Okay.
Thank you, Alan, for the presentation and the invitation, and I am really happy to be here. Some years ago, when I started to work with patient organizations, I started my speech within such similar group of people that I represent the disturbing fact of the excellent healthcare system, the patient. Without the patient, the healthcare system could work optimally and very good. But unfortunately, the patients are always there and they have different problems. So I try to give you a bit different aspect how the patient can see or work together with specialists. And I have to tell you that ONCA is one of the first European networks which requires from the first moment active participation of the patient groups. So I think that this is a very modern or very exclusive body. So I got this nice title. So I try to give my perspective, and I decided to start with this very complex graph from my professional. I'm sorry, I am an engineer, so that I like that. So I think that if you see the center of this picture, the nutritional status and the health status is absolutely related to each other, vice versa, and there are many other facts, and this article from what I copied this picture started to analyze how is the poverty is related to the health status and all the others. So if you see that the nutritional status and the health status is not only the poverty, but also the labor thing. So my problem is always with the politicians, that they don't understand why they need invest more to the healthcare, because when the people is better health conditions, they will be able to work and they will be able to pay taxes more and more, and the balance will be much higher and much better for them. but I can imagine why it's not so popular. So I think that what we can do, we can and we need to increase recognition of the burden of the malnutrition. So the raised awareness of the malnutrition and all the other part is very, very important. And we need to add that this is not only a problem of the elder people, but as we heard many times, that even the children might have this status. So it means that we need to deal of each age group. Then the decision-making process. This morning we got a very nice and very, 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 very plastic example from Portugal, how they are working and how they want to plan actions to achieve the reimbursement of the treatment. So that's a European problem. So it means that we need to repeat and try again if we are refused from some aspect. So it's important that we need to be part of any kind of committees, any level. I mean that high level, minimum level, European level, or even WHO level, but also the local level. So even, for example, in one school, that could be the level where we need to act. Again, the comprehensive care. Again, something that we need to make much more known in the general public. And sometimes the healthcare professionals, not you who are sitting here, but out of this room, some healthcare professionals doesn't understand what they don't understand why the malnutrition or the undernutrition is important to deal with. Evidence-based politics. It's very, very important to, you know that Dr. Google can solve everything and can handle any diseases. How to act against. This is by my experience, is my advice to my colleague, that you never start a discussion and dispute with this. Instead of you had to present the right information to them, and you have to update your society's website and everything to inform and to train your members and your people. Sometimes, again, it's not a popular thing, and sometimes we are refusing when we start to train the healthcare professionals about our disease, because they are saying that I know everything. Yes, you are right. You know everything from the medical side. You learned it at the medical university, but we are living every day, ourselves or our family member, and handling their nutrition if it's necessary. So that's our experiences and our advices certainly different. Not against us, but we are supporting. We must support each other. And also very important to educate and training the patients. Absolutely. We need to disseminate the relevant information and updated information. When sometimes the guidelines changing, we have to explain on their national language what is the main reason and what is the main differences compared to the previous one. And again, the awareness of any knowledge for their chronic illness is very, very important to distribute. And also nowadays is sometimes a criteria that the patient must be involved in the research and development procedures. We are here and we know how to support the good result. And what we can do, so it means that we try to fight for better access for the quality nutrition care, because our aim is the same with the healthcare professionals. A better quality of life, longer healthy years for each patient. And what we need to do, we need to be visible, and we need to be transparent. Previously, always the requirement for a patient organization, you must be transparent. Okay, we are, but we are not visible. It's very, very important to, when a question arises, we are here. If you have a question, we are ready to answer it. We need to be a disseminator of information. We can be a coordinator, and it's again, it's very how it's called, up to date and very, very fashionable. Very fashionable terms now is the unmet needs of patients. Even we need to collect the unmet needs of the nutritional care from our, not only the any kind of patient groups. And I think that the malnutrition policies agenda, I think that we need to be there. And the raise awareness is again very, very important. The coordination is our everyday task, and very, very important to inform the general public, the people on the street. What does it mean, the malnutrition? What does it mean, the undernutrition? And all these terms, you know what does it mean, but the people on the street doesn't know. And even I was in the morning, the micronutrients deficiency is again belonging here. So I think that we have to unify our knowledge and our forces to be more successful. And I think that. The proactivity, again, not reacting, but be proactive. It means that being required from the government, the national nutrition policies, and the monitoring the indicators, and lobby for the guidance for the nutritional care, this case. And then communicate the diet-related non-communicable diseases, that the malnutrition is any of these diseases can be a consequences. And we need to underline that the global burden of the diseases is it causes a higher and needs higher budget from the healthcare. And the good practices from my colleague from Spain, they organized for the Malnutrition Week. They prepared the manifesto, and they elaborate a patient journey guideline for the high-risk malnutrition risky patients. So I think that this is something that we can learn from each other. And the take-home message, again, a graph, and again this that. Showing that, believe me, but believe us, that the healthcare is not something in the space alone. It's related to from the agriculture to the home nutrition and home feeding my family members, and also included the social care, the hospital care, and everything. And we have to somehow work for a better nutrition status of European citizens. Thank you.
Thank you very much for your sensibility and for this particular view on this argument. Well, now it's time to move to another very important argument. This year, ONCA would like to have a special interest on it. I'm talking about intestinal failure, and I am particularly happy about it because I work on it. So it's my pleasure, really pleasure, to invite the next two speakers, who are Sergio Settanni, member of the board of Filo per la Vita, Patients Association in Italy for both children's and grown-ups, and Marek Liota from Appetite for Life, the Polish Society of Association of Patients. Please, the stage is yours.
Okay, thank you very much. Thank you, Antonella, and thank you for the invitation.
You can stay even there if you want.
Okay, I mean, whatever you want.
Maybe I will go over here.
Okay.
Okay.
Okay, we can stay there. Oh, it's fine. Okay, so thank you very much for the invitation, and thank you very much for having given us the... Ooh! Thank you, Marek. So it's really a pleasure to be here, and I would say let's start with our presentation, which is about what I would say the Parent Association can really do in order to, let's say, support creating the understanding of the disease that our patients that we are representing are really living, and how we can really together get to a better understanding. I will just introduce myself. As Antonella was saying, I'm Sergio Settanni. I'm a member of the board of the Filo per la Vita. In reality, I'm not a patient, but I am the father of a 15-year daughter, which is affected, I'm sorry, I'm getting emotional, by parental nutrition, and she's, I would say, connected 17 hours a day for 7 days a week. But I mean, in reality, that's a luxury, because in reality she's growing very well and she's really doing great. So, but I mean, that's the kind of emotions that also comes with being part of a patient association. So I let it introduce yourself, Marek.
Thank you, Sergio. My name is Marek Lichota. I'm a patient, but I fully understand your emotional approach. I have 2 children. And of course, I'm not the one who is satisfied from the fact from suffering from chronic disease. But when it comes to the children, I definitely agree that it's even more emotional. So I suffer from Crohn's. Due to complication of the Crohn's disease, I become dependent from the home nutrition. It led me to gather quite a lot of experience when it comes to improving the quality of life. And that's why also I decided to set up an association in Poland, the association who gathered the same patient with similar problems as mine, so which is called Appetite for Life. So thank you. Thank you. Sorry, because I forgot to say about this. Thank you, ONCA, and thank you, my Italian colleagues, for inviting and for giving an opportunity to share my input. Again, it was not so sure because even 2 days ago I was in a hospital, but I will tell you later something about this. Thank you.
Okay, so as we were saying, just a brief introduction on Filo per la Vita. Filo per la Vita, it's an association which has been founded in Italy in 2005. It represents all people which are affected by the chronic intestinal failure, and which depends on home artificial nutrition, and which in some cases it's also, I would say, leading to transplantations of bowel to survive. As we said, the association was born in 2005 from the parents of another children which was affected by it. And our mission as an organization is really to improve the quality of life of the patients and also to protect the patients in themselves. For Appetite for Life, I mean, we're just doing that so that it makes it a little bit more, I would say, nice to follow. So
Okay, may I have
Sure.
a click?
Yes.
So we focus our activities among the empowering, educating, supporting, and uniting the patients who are suffering from insulin failure, but also who are on home artificial nutrition, and those who are suffering from inflammatory bowel disease. We set up our association in 2012, and we definitely strive for the improvement when it comes to the quality of care for those who cannot eat or drink normally, or at least is so limited that they have some medical issues because of this.
Okay, so when we get to the intestinal failure, in reality, the intestinal failure, the malnutrition is a consequence of the intestinal failure, and in some cases it can also lead to death. And so, in reality, it is important to recognize what is the disease which leads to the I would say, malnutrition. And this is really important that this diagnosis is done in due time, in due course, in order to be able to achieve a minimum standard of care in the treatment, and that it is also provided, wherever the patient is, a common approach to the support of the patient. So this should be, I mean, if you should be aiming to shoot really high, this should be something that should be available with the same level of care in every region, in every nation which is part of the European Union. So this is really what we would dream as an organization. I mean, there have been already some steps which has been taken in terms of recognition of the intestinal failure as a rare disease. In reality, Orphanet and the European community under the Orphanet system has been already codified the intestinal failure as a rare disease. But despite this recognition, right now, this has not been enforced in many of the nations which are member states of the European Union, which means that in reality, a patient which is affected by intestinal failure can have significant differences in the treatment and even in the recognition of his own rights, depending on where he's born or where he's living. So that's really something which is a main aspect that needs to be taken into consideration, and the fact that there are those associations are really one of the reasons why we decided to create it. It's really important that I would say the associations, or I should say the association have born in order to support what the health system wasn't really capable to provide and what the legislation was not really supporting. And so at the beginning, it was really an area and a place where the patient can get together, understand which were the best practices, get some support, even psychological, because you can imagine what could be the consequences of being diagnosed with an intestinal failure and you don't really have that much of a knowledge about it. And so that was the original scope with which most of the associations were born. It was just to get support and supporting each other. But then, in time, when those associations were maturing, we started really to understand that our role was becoming to advocate the intestinal failure and making sure that this was becoming something to be discussed on all the different tables. And so there has been this significant change and shift in the way the associations have started to work together. And once we were going down that journey, we also understood that this is a multi-stakeholders approach, because at the end you need to talk with the politicians, you need to talk with the policymakers, you need to talk with the medical and scientific society, and you need to talk with other parents. So it really requires a lot of effort. And in reality, I mean, we are doing that on a voluntary basis. And so that was make sometimes the parent associations being not as effective as they would be, because in reality time is missing to be able to cover all of that, the willingness and the wishes that the associations are really having. So still in the evolution process, we also started to understand that we need to change the way we are presenting the problem, and we need to start to become a little bit more positive. And so we started to understand that we need to share best practices, but rather than only sharing best practices, it was really important for the associations to start to introduce the concept of the positive impacts of doing certain things. Because at the end of the day, treating patients is too many times seen as a cost, while treating patients properly and in time, it's a saving. And so it's really important that we change the dialectic that we are using in presenting that. So we agreed on the best practices, and we agreed on which should be and how a best practice should look like, and then we started to work on some of those. And as an association, we started to develop our own manifesto, and we were hearing that already from other associations that we were listening before. And we were designing that manifesto around 8 main points, which were all around not only the patient, but even the doctors which are treating the patients, the family which are connected to the patient, and also, I would say, to the caregivers, because you shouldn't forget that the intestinal failure normally leads to a home artificial nutrition treatment, which requires someone which is supporting that. And in most of the cases, the support is the family or someone within the family which is becoming a caregiver. And so it's also important to have a proper training for those resources, because they are significantly influencing how the patient is reacting to the treatment. So we have been working on that, and now we are using this manifesto in order to make sure that any time that we are sitting at the table, we have some common points we can share and we can discuss, either with the policymakers, either with the medical and scientific community, with anybody we are sitting and talking. In addition to that, we also had made an additional significant step, which seems to be simple, but it is not, which was to put together 9 other associations that to a certain extent are treating the intestinal failure and are representing patients which are impacted by the intestinal failure. And together with those 9 associations, we have been invited to present a paper to INPS, which is the social security system in Italy, because one of the other problems lays on the fact that there is not necessarily the same level of recognitions of the level of disability depending on which of the regions you are sitting. We were just listening before that we had right now, we are a federal state in Italy when it gets to the health system. And so in reality, depending on the region where you are, you might have difficulties in getting the intestinal failure being recognized. And so we have been preparing a paper which has been introduced to the INPS and which is going to be taken hopefully into consideration, and which is really focusing on supporting the commissions, which is making the evaluation of the case, with Center of Excellence, because one of the things that we have been working together with, also with Antonella and with many others colleagues, has been really to create centers of excellence within the territory. And by doing that, we have been proposing to the social security system to support the verification which is done of the level of invalidity by experts and professionals which are coming from those excellence centers. And then, again, to go to the direction of saving money, to remove the need of revising the diagnosis with a certain frequency, because this is absolutely something that in the case of intestinal failure or chronic intestinal failure, it doesn't really make so much sense, because there are not significant evolution on time, and this will enable the system to save money. And then also to, I would say, work together with them to create a work stream with the scientific community and the commission in order to evaluate the cases and support, I would say, a proper treatment of the patients. So those are some of the best practices that we have been starting to do as an association in Italy, but obviously there are also some other great cases that now Marek is going to be explaining to us.
Yes, so first of all, thank you, Tunde, for a great introduction. Probably despite of all the activities with the patient advocates can do, we're supposed to advocate for more patient advocates, because it was quite a long list of the things which we can do. But of course, the raising awareness and the education is something what also makes you to have more I mean, to be more open to listen us as a patient perspective, but also authorities. So that's why it also stays among our points of interest. So we are deeply involved in the matter of organization of different educational activities, like workshops, conferences, which refers to the home nutrition, inflammatory bowel disease, intestinal failure as well. And that's, I was really pleased and proud to be a part of this Vienna Declaration, which was cited and mentioned several times when I had the chance also as a member and the representative of a patient societies to present a patient perspective on this important topic. Of course, we run different campaigns, informational campaigns. This refers to the IBD, but also we're trying to be present at the media. It's not so easy to draw the attention in regards to the intestinal failure or bowel problems generally when it comes to the media, but we are trying to find at least a way. Of course, we have to find our ambassadors also among the other patient organization, patient advocacy groups, like Onco Alliance, like different chronic disease organizations. So that's why we are taking part in different alliances and patient advocacy groups conferences. That's one of our recent activities which referred to the matter of the rehabilitation. We were presenting a ERAS approach. That's a part of it even before the surgery. Definitely the patient advocacy and the police engagement, that's also a big part and the important part of the story. So we have a proactive approach when it comes to the contact with the Ministry of Health, with the National Health Fund, Health Technology Assessment Agency, and other health-related institutions. That's a long story. For the last 8 years, it was not so easy. Probably some of you may know that we have a hard, let's say, times, if we can say so. Of course, let's keep the politics. Nevertheless, it looks, of course, it's at the local level, national level, but also at the EU. You can find nice pictures of the key opinion leaders and the expert Simon Stefan. Once also, once we went to the European Parliament to draw also the interest to the intestinal failure issue, and it was quite successful. Maybe there will be a chance to develop this in the future. That's also a part of a COVID moment, as you can see, when we have to find a way also to reach the authorities. And that's one of our most recent activities. That's a special parliamentary committee which refers to the network or regulation which it comes to the national network of oncology, and we were fighting, maybe fighting, that's not, we were advocating for raising importance of the nutrition when it comes to the oncology treatment, together with the chairman of the Polish Society of the Patient-Centric Nutrition and one of the key dietitian nutritionists from oncology centers. That's not so real. I mean, we did not draw so much attention of the media. Nevertheless, it's always to have a good moment to have a test. And that's a nice picture of, together with the members of the Polish Parliament, current members of the Polish Parliament. The one in the middle, she's a candidate for a EU Parliament with some chances to get into the EU Parliament. So hopefully, fingers crossed. And Annemika said about the elections in the Netherlands. We will have an elections on Sunday. So hopefully not only we will be able to build the ground in Poland, but also at the EU level. And that's also an interesting issue which can open, and that's quite often that it can open, help you to make a change. At the end, the guy on the left side, he's also a member of the parliament, but he's also a Crohn's patient. So he's suffering from a Crohn's disease. He goes through the tough time, and he's also fed but enterally. So he initiated a special parliamentary committee which referred to the matter of the nutrition, and it will also help us to build some kind of politics regulation when it comes to the importance of the nutrition. I'm sorry to miss the lady in the middle. She's a Ministry of Health, and that was first time when the Ministry of Health was really in the middle of the some kind of activity or event which referred directly to the matter of the nutrition in the context of medical issues. So that's something what was really important for us. That's a part of the committee. But at the end, that was also a question here raised by the Annemieke, what is the real change at the end, what has changed? So we are always proud and we are also always happy from the fact of seeing and touching the real patient stories and making all the people who are suffering from intestinal failure from such condition to bring back the appetite for life, to enjoy. We have holidays in front of us, so we are really happy to get the feedback from them that they are more open, more eager to overcome their barriers, which refers to the intestinal failure and home nutrition, which is quite often connected. That's sorry, one of the important moments in our history. Last year we celebrated the 40th anniversary of the first HPN patient in Poland, which is, I think, quite an important event, and I'm also happy about the fact to get some kind of recognition of our activities as an appetite for life among all the experts and the people who are so determined and so involved in all those activities. It's, of course, it refers to the Polish part, but taking into account that still the war in the Ukraine exists, as a patient association, we were also involved in helping the patients from the Ukraine. There are not so many patients with at least the ones who we can locate from the Ukraine who suffer from intestinal failure, but the small girl from she's from Ukraine, she's dependent from the Patient-Nutrition with the intestinal failure due to Hirschsprung disease. So I was personally determined also to transfer her from Ukraine, from Dnipro, then to Poland, and then finally that's the picture taken last year. She's in Germany, so I would like to thank Alger Tessin, my friend, who helped me a lot to transfer her and to find the proper care there. So as you said, when when you wish to see the difference, that's the moment which really makes you to have a sense of, to get the sense out of this, what you are doing, because sometimes you have to do something at the very top of the activities when it comes to the regulation, when it comes to the policy, but then you really are more satisfied when you touch the real people's lives. So just to resume, because it was my idea to call our session Uniting the Patient Voice. Are we ready to accept the challenge? Because probably some of you already know that we did our best and put a lot of efforts and energy to create some kind of structured legal alliance of the patient organization together with our Italian colleagues, but also the patient association from Great Britain, 9 other European countries. But to be fully honest, I have to regret and I have to say that we failed. We were not able to fulfill all the legal, all the financial difficulties, taking into account that we have already a lot of our national level. That's there were not so many resources which we can use at the upper level. Nevertheless, definitely we have a common understanding that there is a need and space for such an organization. Even if it's not structured, we have to find a way to keep the momentum, to keep the communication between us, because we really believe, we trust, and we totally understand that you are the ones who provide us a care and you are the expert, but how that kind of condition impacts the patient life, I think that we are, as a patient or as families of the patients, we have the expertise. Of course, that's something what also it's quite, I think, convincing that we are the most engaged advocates for fighting, because it's because it affects our lives. So therefore, we are really engaged to make a difference, to help to save our lives, to save the lives of our families. Of course, we wish to be partners together with you, with the industry, with the healthcare societies, as we believe that we can really provide a lot of feedback. If all your efforts also make a difference when it comes to the patient patient life, I think that also it's important. And that's something what I wish to also, probably you know this, nevertheless, that's our issue that we really dream and we really wish to achieve a lot. But being a patient from one side is our biggest strength, but on the other hand, it's also our biggest weaknesses. And that's why we cannot, overcome all the problems. As I said, I was not able to come last year to Amsterdam because my kidney stone stopped me from being together with you. And this year, 2 days ago, on Monday, I was admitted to hospital. On Saturday, I was admitted to hospital. On Monday, I had a gastroscopy and a colonoscopy test. And I was really afraid that I won't be able to come. My hemoglobin level is really poor. But I was so determined to come to you this year to share my story, also to hopefully somehow inspire you, also inspire your patients in your countries to try harder. We really put all our hearts into it. But sometimes we are also a patient, so we cannot predict, and it's not fully up to us. So thank you, and if you can say the final word.
No,
so.
I mean the final word. You have been really touching, I think, the heart of many people here. So thank you very much.
Okay, so I think that we can.
Okay, so we're going to ask.
Yes.
We're going to ask all
Please
four
take place.
speakers
Yes.
to take a seat. Rocco.
Now,
Annemieke.
really, thank you very, very much. We are grateful to you for coming and sharing with us all of that. For sure, we must
And Tunda, please.
try harder.
Tunda.
And I think we will give more space to
Tunda.
the patient-reported experiences and outcomes. It's very important. Well, any question from the audience?
Well, I'll start.
Maybe a lot of...
I'll start while people are thinking.
Yeah.
Well, we all know about the World Health Organization, and it's, of course, playing a very important role. We listen to them. But Rocco and Annemieke, what is the most important part of actually working with them? What can they do in the end that is really meaningful? I mean, because we all know about it, but maybe we don't know why it's so important. So could you just give us a few words?
Okay, maybe I can give a perspective. I think that, again, they cannot change policy in our everyday life. They cannot do that. They are, well, not really even a supranational organization. They have offices in every country, as far as I understand, in every part of the world. But their role is not to promote, or rather to change policy again, but to, let's say, advocate. This is what I think is the right word. So they are willing to advocate for what they believe are the priorities in healthcare. And again, the idea is that we would try to contribute to make disease-related malnutrition one of the priorities, which to a large extent, I believe, has not been the case so far.
Yeah, and I think it's very important that we put nutrition and undernutrition on the map also in the WHO in order to get it into the policies. And of course, it should be translated to the countries, but I think it's important.
If I may add just a small thing, I think that if we are able to build or to create some content, some messages that they are willing to share with us or to prepare or to... Because this is how also they operate. Of course, there is a political level where I understand they operate and they speak to ministries of health in different parts of the world again. But also some of the tools that we can generate together, we can use in everyday fights that we are sharing against disease-related malnutrition and aging-related malnutrition. I think it can help. Like the Vienna Declaration, we know it's not going to change immediately or directly our life, maybe, or anyway our policies, but it can be used as an argument, as a topic, as a tool. So I think maybe the same can also be the case for WHO documents that we can generate together. Plus, if they are really becoming engaged, they might make the disease-related malnutrition one of their, we hope, main topics for the near future.
Well, I must say that I've been very impressed with what you have achieved, both organizations in just very recent years. I know it's been very difficult to actually get into having their involvement, and I must say you've been very successful. And I think this is a good example of, because in the end, this will be a top-down recommendation focus from a very important advocator, obviously. So my question then goes to the patients and you are doing the bottom-up thing. And of course, we've heard a very, touching and moving stories about how life is with very, very life-threatening disease where nutrition is key. And Marek, you reminded us that it's not so long ago that this was impossible. I mean, we're talking 50, 60 years and this, people would not be alive.
Yeah.
So how do you feel your movement is coming up and how you can move these things? And how do you think that you can influence also people on the top in different ways?
Would you like to start?
Okay, no, I can start with that. And yeah, I mean, it's quite obvious that when we look at the intestinal failure and and we look at the malnutrition in itself, we are talking about sizes of problem which are order of magnitude of difference in terms of number of patients and potential people which are involved. But in any case, the simple fact that we are already sitting at this conference here proves the fact that even with small steps, you can really, I would say, contribute in the discussion and contribute in advocating the needs of the patients that we are representing, or that we are in this case. And in reality, it also helps maybe understanding, because it's key, understanding really which are the needs. Because sometimes the stakeholders which are sitting at the tables might see things from perspective which are obviously severely conditioned by the association that they are representing or the company that they are representing. And in reality, having the chance of sitting at the table, discussing about what are the needs and being clear on that might also help the conversation getting in the direction which is then the most, I would say, valuable for the whole stakeholders.
I think that's an extremely important point that you're making, that actually it is about understanding what the situation in reality is. And of course, it is impossible for anybody outside, to really understand, but you can help us understand.
Yeah, if I can add something to it, I also totally agree with you, and I think that we have some kind of ability as a patient maybe to say it in a more simplified way, which will be more understandable for authorities. I do not get nothing from the fact, but sometimes the medical knowledge is so sophisticated, especially when it comes to the so complex medical condition, that when you are able to share the real patient story, which I think that it is really powerful to draw the attention, and then you can put the context of the issue. Definitely, that's the way how we can also approach and make a difference when it comes to the understanding of the problem. Tomorrow we will be discussing the intestinal failure campaign, maybe, which will be a part of the ONC activity. So I will invite you, and maybe you will be able to help us also to find another patient stories which we will be able to share and also make a difference at your country level, but also internally, externally at the European level. Mm-hmm.
Sorry, you mentioned before your positive impression. Yeah. Yes, I think it's, I'm really touched about it, and I think this must be taken to up, from bottom up, because this is a really very important message. And I think you, all of you know that intestinal failure treatment is a real revolution of the modern medicine, isn't it? So we must be proud about it. And maybe our governments or health managers may realize that that way they are saving money.
Yep.
Do you agree?
I think everyone agrees. Rocco, please.
But so, if I may just say a small comment, make a small comment on this, and I hope this is not misunderstood. Marek, we know each other for some time. You were speaking in Vienna at the declaration session, so I think that it is really not under debate the importance of nutrition, intestinal failure, and so on. I think that we maybe step by step will need to extend the view and the scope and the awareness. I think this is a little bit weaker, that when maybe nutritional care is not immediately saving life, like in the day by day or in the needs that patients have to survive. That's also quite important. I think that we need to increase awareness. I see Manuel Arellano here. I think that we had started this discussion already. I think that this is not only true for intestinal failure, and we are all aware of that, and we need to increase awareness about the importance of nutritional care also in other diseases. Again, this is not to be limiting, but to be expanding the view. So.
Yeah, we'll take questions. Do we have the microphones? Somebody? Can we have the microphones? Please? Over here.
Thank you. Declan O'Brien from the British Specialist Nutrition Association. We represent parenteral nutrition production in the UK. It's just a question of awareness. In the UK, we're predicting 5% growth in demand per year over the next decade, which represents, and I was corrected on this, 63% growth in demand in 10 years. Infrastructure-wise, this is a very challenging industry. And people-wise, this is a very challenging industry. Is there awareness of this across the various countries?
I don't know.
What do you think?
If I understand correctly what you're saying, I hope that we will have that kind of challenge, that the production of the supply might be increasing so that it might challenge the industry to produce this kind of treatment, because it would mean that really we are succeeding in implementing nutritional care. Do I understand correctly?
Yes, but I mean, with our aging populations, we just see demand increasing over time. And it's something we have to plan well in advance, because it can take 2 years, for instance, to build a production plant site. It can take even longer to get the people to operate it, because operating these sites are very specialist individuals. It's just a point of awareness that we all need to be aware of. And the other bit is you can't buy your way out of the situation, in the sense that in some industries, you can just pour more money in and increase production. In the parenteral nutrition area, you can't, because it takes so much time and so many people. So it's not something you can have an instant solution to. And also, generally, you can't import or export the products, because everybody's struggling to meet their own national demands. Thank you.
Okay. If you are talking about sustainability, maybe, of the treatment, we must consider as well the cost effectiveness of the treatments, not only sustainability straightforward. Thank you.
Yeah, Annemieke?
If we listen to policymakers, they talk about food inequality, food insecurity, and if we look at the nutrition as a human right, I think we have an open goal or something. We can just put a ball in it and use this as a way to communicate. And Marek, you was attending that meeting and talking about the Vienna Declaration, nutrition as a human right. So how can we use that to address food inequalities and the fact that we need reimbursements for all those kind of products, but also services, dietetic services, physiotherapists, all the specialists. How can we use this? Do you have any idea? Because I'm a little bit positive and opportunistic maybe, but it's an open door, I think.
Yeah, that issue has got different layers. I think the key issue is that we have so different situation from country to country that imposing this from the top to down, that's not always so effective. I mean, the name of our conference is Optimal Care for Nutritional Care for All. But then we have to look deeper into the local conditions and to see how it might be implemented. So definitely when there is a need, there is a way to achieve it. So probably we need more people who are so determined to make a change. I mean, that's always a part of the story. So let's believe, let's lobby for the other patient advocates. And I will also, when it comes to the demand of the clinical nutrition generally, it's also about the teaching or having the clinical nutrition as a part of a curriculum at the medical universities. That's also a part of it. I know that you are, as an ESPEN, taking a lot of activities into it. But again, that's another issue, especially according to nurses, dietitians, who need to be a part of it.
Okay, I'm going to make that be the last word of this discussion. I'd like to thank our speakers and our panelists. We have, and I also like to thank the audience who has been with us online, and we're now finishing the streaming service. Thank you and good luck, and keep the nutrition work going. For all of us, we have two very important things to do now. We are going to follow our photographer downstairs and go outside of the building to take the photograph. We do that every year. So we go straight down there, and only if you join us there, you will have coffee up here afterwards. Okay.